Good morning. Welcome to the first committee of the Interim Committee on Health and Human Services on January 6th. As we begin today, I want to welcome everyone. Secretary, would you please call roll?
Senator Donate, Senator Lang,
Here.
Senator Titus, Assemblymember Edgeworth, Assemblymember Golding, Assemblymember Hibbets,
Here.
Assemblymember Nadeem, Chair Brown May.
I am here. Just want to make sure that you saw that Senator Donate is with us. He was having difficulty with his microphone. So first, welcome to the first meeting on the interim for this committee. A couple of housekeeping items as we begin. First, I want to remind everyone to please silence your electronic devices. Mine was just singing to me a minute ago. Committee members will be utilizing laptops and other electronic communication means to make sure that we're following along with presentations. Please don't take that as a sign of disrespect. Our agenda is posted. Agenda items may be taken out of order as we will just proceed naturally throughout the course of the day. Additionally, 2 agenda items may be taken together. We're going to hold for just one moment. Apparently, Carson City cannot hear us.
Hello, Chair. This is Jen from Broadcast in Carson City. Could you say hello for me real quick so we can check the volume up here?
Hello, Jen.
Okay, great. Thank you very much. We can hear you up here. You're just a little bit quiet. If you want to go ahead and roll your meeting, we will work on turning it up in here.
Thank you.
Thank you.
I can tell you no one's ever accused me of being quiet.
Great. Thank you so much. Have a great meeting.
Thank you so much. Thank you. Okay, we'll go back into order at this point and into the housekeeping notifications. I hope that you could all hear us in Carson City at this point. Please make sure you silence your electronic devices at this point. Agenda items may be taken out of order or combined. Committee materials can be found on the website. And if you want to testify in person, please sign in at the table by the door. If you do not, you can also sign in and you don't have to testify. Make sure you turn your microphone on when you do come up to testify. And with that, we will now continue with our introductions. I'd like to take a few minutes to introduce this interim committee to the members of the public and to each other, as we have a number of new staff members that have joined us. First, we're going to start, if you don't mind, with Vice Chair Senator Danyate. Would you tell us a little bit about your background, the district that you serve, and a history of serving on this committee?
Thank you so much, Chair, and good morning, everyone. I'm State Senator Fabian Danyate. I proudly represent Senate District 10, which is in the central Las Vegas region. I have served on this committee for several years now. I was appointed in 2021, elected in 2022, and have served as a chair on the Senate side since 2023, and so very honored to get to serve on this committee. And am I forgetting anything else?
No, I think you're
All right, thank you so much.
Senator Lang.
Good morning, I'm Senator Lang. I represent Senate District 7 in Las Vegas, and I have served on HHS for many years as well, both in the session committee and the interim committee, and I'm thank you for having me on.
Thank you. We'll go up north to Senator Titus.
Thank you, Chair. First and foremost, thank you for allowing me to be on this committee. I look forward to working with all the other members and actually throughout the state with people in concern. We have opportunities to solve some big issues here in the state on healthcare. Having said that, I'm Senator Titus from Senate District 17. I am proud that I'm the only physician in the Senate, and hoping someday that will change. Healthcare is critical. My major reason for running. I represent 6 rural Nevada counties. I still, although I don't see patients on a day-to-day basis, still make house calls, still have on my phone, if you ever call my personal phone, you'll say, if this is an emergency, please dial 911, because people still call me. And so I also am still the Lyon County Health Officer, and so I'm still practicing, and I work for Lyon County School District. So healthcare is key. For me, access to care is really the term I use. We can all agree that everybody needs to have access to health care. It's how we get there, and who pays for it is one of the discussions that we'll be talking about here on this committee. So again, Chair, looking forward to working with everybody. Thank you.
Thank you, Senator. This time we'll move to Assemblymember Goulding.
Good morning. Thank you very much. I'm Heather Goulding. I represent Assembly District 27, which is on the north side of Reno. I served on the HHS committee, the Assembly HHS committee, during my first session here a year ago, and I'm delighted to be here during the interim. Thank you very much, Chair.
Thank you. We'll go next to Assemblymember Nadeem.
Thank you, Chair. My name is Hanadi Nadeem. I represent Assembly District 34. I'm honored to be in this committee, and my passion is to make healthcare more accessible and affordable for my fellow Nevadans. Thank you.
Thank you. Assemblymember Dr. Edgeworth.
Good morning. Thank you so much for letting me be on this committee. I'm very excited. I was in HHS committee during my first session that just wrapped up a year ago, I guess. I represent Assembly District 35, which is down in Southwest Vegas, down in Southern Highlands. I am the only practicing physician in the Assembly, so there's 2 physicians. I'm very excited, and I totally agree that we should have more medical things because medical concerns are a very high priority for our state. I work as not only a physician, but I also am a professor at a university teaching the next generation, and I work with a lot of underserved populations, so I too am very excited about helping get access to quality health care for all Nevadans.
Thank you. Assemblymember Hibbett.
Thank you, Chair. Brian Hibbets, Assembly District 13, northwest portion of Las Vegas. I've served on the HHS committee in both 23 and 25 session, and the interim committee last interim. Thank you.
Thank you. Myself, I'm honored to serve as chair of this interim committee on Health and Human Services. Tracy Brown May, I represent Assembly District 42. And I've spent the last 2 decades working on the human services side of Health and Human Services in support of our disability population throughout Las Vegas. Like the senator, I was appointed in 2021, and I'm honored to continue to serve in this role. As we move forward, we're going to hear now from the many staff members that support this committee, because while we are elected as members and represent our constituents, we certainly cannot do this alone. It does take a number of very talented staff members to make sure that we are able to proceed. So we're going to start with our legal division and Eric Robbins.
Hello, Eric Robbins, LCB Legal. I have been staffed this committee since 2014, and I've staffed Senate Health and Human Services since 2015, and I'm excited for the committee.
Thank you, Mr. Robbins. We're happy to have you here. We're going to go up north to Mr. David Nass.
Thank you, Chair. David Noss, LCB Legal. I have been working on Health and Human Services for the past 4 years about now. I've been on the Assembly HHS for the past 2 sessions, worked on the Seniors, Veterans, and Adults with Special Needs Interim Committee, last Interim Committee, and excited to be helping to staff this committee this year. I also am counsel for the Nevada Youth Legislature. So excited to be here and to continue to help this committee as it works to make healthcare better in the state of Nevada. Thank you.
Thank you, Mr. Nass. Now I'd like to introduce you to one of our newest members on the legal team, Mr. Carl Kawambe.
Good morning, Carl Kawambe from the legal division. This is my first time staffing this committee, but I'm very happy to be here and looking forward to contributing to this committee's work. Thank you.
Thank you, and officially welcome to Nevada. Now I'd like to turn it over to our senior policy analyst, Davis Florence.
Good morning, and thank you, Madam Chair. Davis Florence from the Research Division. I've been with the LCB for about 3 years, and this is my second time with this committee. Most recently staffed the Assembly Health and Human Services with our chair. Thank you.
Thank you, Mr. Florence. Now we'll move over to our senior policy analyst, Mr. Chiaramella.
Thank you. Anthony Chiaramella, Senior Policy Analyst, Research Division. This is my first interim committee, and happy to be here. Thank you.
Thank you, and welcome. Additionally, I want to call out the assistance that we received from a number of our committee secretaries, Serena Hale, Christina Harper, John Sarah, all from the Fiscal Analysis Division, as well as staff from General Services, our audio-visual team, our hearings, AVH. Thank you so much for all that you do and for helping us to be successful as we work through the interim. So thank you for the work that you've done and the work that you will continue to go as we move forward. Now with that, I'd like to move into our public comment period. Public comment is item 2 on our agenda. Public comment will be limited to 2 minutes per speaker. Staff will time the 2 minutes. If you are interested in offering public comment, please come forward up here in Las Vegas as well as in Carson City. Remember to turn the microphone on when you are ready. In addition to testifying in person, you may provide public comment in lots of other ways, all of which are listed on the agenda. And go ahead, you may begin when you're ready.
Good morning, Chair and members of the Joint Committee. My name is Sue Birch, S-U-E-B-U-R-T-C-H, and I am the Executive Director of the National Organization for Women, Nevada State Chapter. Today, I am representing NOW and a coalition of women of all ages and backgrounds and from other organizations, and we want improvements to reproductive health care in this state, something we are calling a Reproductive Health Care Bill of Rights. This is our rough draft. Yeah, I know. We manage our reproductive health for more than half our lifetimes, our periods, our fertility, and finally those dreaded hot flashes. But what about all the other issues? Endometriosis, risk of heart disease, strokes, etc. It's all connected. We know we'll be asking for a considerable investment. one that will improve education, research, and training. But we also know that the dividends will be substantial. Yes, we've made some improvements. And yes, we elected the first female majority legislature in the country. So why do we consistently rank near the bottom for women's health care? We're tired of being told to suck it up, tired of being told our symptoms are all in our heads. We're tired of Band-Aids on our symptoms. We're half the population. We deserve the investment, and I thank you for your time and Happy New Year.
Good morning, Madam Chair and members of the committee. Stephen Cohen. For the record, I would defer to the written remarks I submitted, which may have just been submitted to staff. Thank you.
Thank you, Mr. Cohen. I do want to go ahead and get on the record the telephone number to call in if you are interested in calling in. If you'd like to call to provide telephonic testimony, please dial 888-475-4499. And then when prompted to provide the meeting ID, enter 891-2994-9350, then press the pound sign when prompted. With that, we will go ahead and move up to Carson City. You may begin when you're ready.
Good morning, Chair Brown-May and members of this committee. My name is Catherine Nielsen, Nielsen. I'm the Executive Director of the Nevada Governor's Council on Developmental Disabilities. Thank you for allowing us to provide public comment today. I'm speaking briefly to highlight the written testimony that we've submitted for the record regarding emerging disruptions to applied behavioral analysis, or ABA, services across Nevada, and to share early observations from an ongoing data collection effort. Less than 12 hours ago, we released a short Google form to Nevada families to help document changes to ABA coverage, costs, and services and accesses beginning on January 1st, 2026. In that short time, we've already received 32 responses, with additional responses continuing to come in. Even at this early stage, the information being shared is notably consistent. Families are reporting increased out-of-pocket costs, the introduction of new copays and coinsurance, coverage denials, reductions in authorized service hours, and delays or pauses in services. Several families also report receiving limited or unclear explanations for these changes, and these experiences appear to be occurring now and are having immediate effects on families. For families who rely on ABA, particularly those children receiving early intervention services, unexpected reduction in services and denials or new financial barriers can disrupt progress and create instability during critical development periods. Our written testimony provides additional context and why this issue is significant, how it intersects with workforce and system capacity challenges, and what the early data is beginning to show. We've submitted the initial Google form results with written comments and testimony, and we'll provide the additional results as they come in. Thank you so much.
Good morning. My name's Patrick Kelly. I'm with the Nevada Hospital Association. We believe there are two areas in need of better understanding to support quick and effective decision-making during the next session. First, we urge the committee to conduct an interim study on access to care focused on identifying root causes and developing practical solutions. Across our state, urban and rural, patients are experiencing longer wait times, difficulty finding providers, and growing barriers to timely care. The study should examine what's driving these challenges and what policy, funding, and systemic improvements can strengthen access statewide. Key components of the study should include a statewide assessment of access challenges, including wait times, provider availability, and geographic gaps. Identification of root causes, including workforce shortages and capacity constraints in various care settings. Evaluation of Nevada's healthcare workforce pipeline, including recruitment, retention, training capacity, and clinical placements. Review of state-funded workforce initiatives to determine what's working, what's not, and what's producing measurable results. An analysis of health insurance, network adequacy, and associated challenges. Review of best practices from other states, and the development of an action plan to improve timely access to care. Secondly, we recommend an interim study on the impact of H.R. 1 on Nevada's healthcare system. A comprehensive assessment of the provisions affecting Nevada, along with anticipated costs, operational impacts, and mitigation strategies would be extremely valuable. Nevadans need a clear picture of how these changes will affect both consumers and providers and what steps can be taken in Nevada to mitigate harm and protect access. Thank you for your consideration, and I wish you all a very healthy new year.
Thank you. Is there anyone else here, either in Carson City or Las Vegas, who would like to offer public testimony? Seeing none, with that, we'll move to the telephone lines. ABH, is there anyone on the telephone who would like to offer public comment at this time?
Thank you, Chair. If you would like to provide public comment, please press star 9 now to join the queue.
Good morning. This is Dora Martinez. Good morning, Madam Chair, Vice Chair, and members of the awesome committee. Just a reminder that here in Northern Nevada, at the Washoe County District Office, Health Department, they are doing free flu shots tomorrow, 1:30 to 6. I just want to put it out there in case people didn't see that. And it's totally free. You don't need insurance. Just go in. No need for appointments. So please get your flu shots. I want to thank all of you for listening, and remember that all of us, we can do so much good and for our Nevadans. Thank you, Madam Chair. Happy New Year.
If you've recently joined and would like to provide public comment, please press star 9 now to join the queue. Chair, we have no additional public comment via the phone line.
Thank you. Okay, this time we'll move to agenda item number 3, which is a review of the interim work program, and I will turn this over to Mr. Florence.
Good morning, and thank you, Madam Chair and committee members. For the record, I'm Davis Florence. I have the pleasure of serving as committee's policy analyst. My colleague Anthony and I are going to briefly go over the interim committee brief. But before I begin, I just want to remind all of the members that staff here from the research division and other divisions are here to assist you in any way as possible, especially as we're entering the new year and you begin thinking on your personal BDRs or the work you want the committee to be focusing on. We are here to assist you with that, so don't hesitate to reach out. With that, moving into the review of the committee brief, I would note that each of you should have a copy in front of you, as well as a version that is uploaded to the committee's website. So going into it on page 1 is just a brief introduction along with the assigned members, alternates, and staff from each of the research, fiscal, and legal divisions. Moving into page 2, you'll find the committee's authority and responsibilities. You'll note that the committee considers a wide range of health and human services topics. This includes child welfare, health care and health insurance, behavioral health, mental health, public health, and many other issues. This includes the jurisdictions of the 2 standing committees from the Senate and the Assembly, along with a few additional items that were carried over from the Legislative Committee on Health Care. You'll note that the committee is able to request up to 15 bill draft requests that relate to the topics within its jurisdiction. Of those 15 BDRs, 5 of them are limited to issues relating to child welfare, and the committee must finish this work by September 1st of this year. And you'll note later on the committee's work session is in August. The next section covers committee's scheduled meeting dates that we have so far, along with a tentative list of topics that the chair has identified to be prioritized. To just quickly summarize those, you'll notice the February meeting is going to be prioritizing maternal, fetal, and infant health. March will prioritize public health and healthcare workforce. May will be focusing on mental and behavioral health. And June will be evaluating issues relating to child welfare. And then the final meeting of the committee is going to be in August to determine the committee's 15 BDRs. I would just note that the items in those meetings are not exhaustive, and any other pertinent matters that the committee members or committee chair decide to focus on can be included. And with that, Madam Chair, that concludes my portion, and I would pass it over to Mr. Chairmella to cover the rest.
Thank you. Anthony Charamella, LCB Research Division for the record. To continue with our presentation of the committee work program, you will find past committee action on page 3. At the conclusion of the previous interim, the committee approved 14 recommendations for BDRs. Of those 14, 8 were then passed by the legislature and signed by the governor. The table on page 3 provides a brief overview of these bills and their status. The original forms of these bills can be found on the JISC-HHS bulletin, which is provided at the top of page 4 in the additional resources section. The additional resources section outlines the various materials available to this committee, whether mandated or published by the LCB, to support the work of this committee concerning health and human service issues in Nevada. Along with committee bulletins, there are legislative audits. The goal of the legislative audits is to provide independent and reliable information to the legislature about agency operations, functions, and programs. For this committee, relevant legislative audits from the previous and current interim include inspections of governmental and private facilities for children to determine if the facilities adequately protect the health, safety, and welfare of the children in them. Information security related to the Silver State Health Insurance Exchange. Audits of the Division of Healthcare Financing and Policy, DHHS, hospice care claims, and fiscal agent contract to determine if proper oversight, control, and applicable laws are being adhered to. An audit of the dual enrollments and supplemental drug rebates to determine if DHCFP was adequately monitoring activities related to managed care enrollees and drug rebate payments. Moving on to page 5, you will find information regarding statutorily required reports. As you know, the legislature requires various state and local entities to provide reports to the legislature, and a variety of these reports are transmitted directly to the committee. These reports can be found through the Research Library's website, or staff can assist you in accessing these reports. The table on page 5 lists newly required reports that were passed in bills from the 2025 legislative session. Some of these reports include information on planning for long-term care, licenses to practice medicine by qualified graduates of foreign medical schools, and lung cancer screening access and inequities. I would note that there are many other reports that are required to be sent to the committee. This table just demonstrates the new reporting requirements. And with that, this concludes our presentation, and we stand open to any questions. Thank you, Chair.
Thank you. Members, are there any questions?
Madam Chair.
Senator Titus.
Thank you. I just want to first thank you, staff, for putting this together, and also acknowledge Senator Donate's work and effort of this committee last interim, and how impressed that, frankly, people may not know that in the past, this committee, although we might have 15 bills, very few got passed, and it was an opportunity to make a difference in healthcare, and to have 18 of the 14 bills introduced actually enacted is a big lift. And so I just want to acknowledge the work the committee did last interim. Thank you.
Thank you, Senator. I agree wholeheartedly, as there was a lot of work that was done collaboratively to make sure that we were well prepared to bring those measures in. So congratulations to our senator and the rest of the team. On a go-forward basis, Senator, thank you for bringing that up. That is exactly how this committee is intended to function this interim as well. The lessons that we learned and how thoughtfully we can proceed through the interim will well prepare us to be able to bring measures that have a bit of consensus around them, so that we can pass measures in the next legislative session as well, looking to have the same level of success. We are open to hearing as a committee from the community, so that we are able to address the issues and items that are relevant to our constituents and the residents across our great state of Nevada. So all of the members of our public and our members on the committee are encouraged to bring in issues that they would like to see addressed by this committee, so that we have an opportunity to fully vet them and identify relevant policy that we can bring into the next session. You will note as we go forward, public comment will be offered both at the beginning and at the end of each of our meetings that we have scheduled, and policy recommendations and considerations are encouraged from members of the public. That did us well, I think, as a committee during the last interim, and we were able then to be very successful, as noted by Senator Titus, with the work that was done. So I will continue to reiterate as we go forward, please bring your ideas to this committee so that we have an opportunity to bring policy issues forward. With that, we're going to move into the next item on our agenda. Given that there are no other questions from committee members or comments at this point. And the item agenda that we have brought together today is to first familiarize this committee and our community with the changes that are happening within the Nevada Health Authority and the Division of Human Services. There are a number of changes within names and structure and departments that are moving. So I think as we move forward, the first thing we want to do is develop clarity around those two areas. So first, I would like to welcome the Nevada Health Authority to the table so that they may begin their presentation. And then members, we will break as we go through specific areas so that you can ask questions. So if you do have questions, please note that. But we would like to break this up into bite-sized pieces so that we can seek clarity as we go forward. With that, I will officially turn this over to our presenters and welcome them to the table. You may begin whenever you're ready. Thank you for being with us.
Good morning, Madam Chair, committee members in the North and South. Happy New Year. We're glad to be here and to see you guys again. I'm Stacy Weeks for the record. I'm the director at the Nevada Health Authority. I have with me Allison Janko-Herzik, who is our deputy director and serves in the role of the chief of staff at the department. Happy to go through everything in our slides, and in the interest of time, I will be presenting all of them. And then when we open up for questions, I have our administrators here and others to address any specific questions about the programs, and happy to dive in. And so we'll go ahead and get started. Let's see if I can learn how to use this. Okay. So real quick, we're going to talk a little bit about the overview of NVHA. A lot's happened since last session. Within, pretty quickly, I think we had less than 2 months to stand up a new department, and then we had a cyber attack, so it was a lot going on the first 6 months of our department. But I'm happy to say that we have fully transitioned into our new department, and I'm very pleased with the team that we've been able to build and are moving forward with all of our day-to-day work and new projects that we've been given from last session. I want to walk through a mission that we've kind of outlined, our strategic priorities. We're putting together like a 3-year target or business plan for our work, and we're also going to be doing a public workshop in a couple weeks to walk through that. Also want to walk through the major projects that our department is working on and some specific legislative updates and status. If you have specific questions about specific bills, I'll do my best and with our team to try to answer them. But we have been doing large stakeholder meetings every 6 months since last session, actually, to provide very specific updates on each bill. So if you have questions, we do have that available, and I'm happy to talk about that. And then just walking through kind of what we're focusing on for the coming year, and hopefully getting feedback from all of you on that focus, and if we're missing anything and there are things that you guys would like to see that we're looking at, and then we'll open it up for questions. All right. So last year, last session, and we had Senate Bill 494 that did what we kind of really call agency reorganization across the state. It really took DHHS and divided it up into 2 agencies, and also brought in other healthcare agencies into one Nevada Health Authority, which we are now under one umbrella. DHS is still it's a Department of Human Services, and it really focuses on that direct care and the direct public benefits that the state provides to Nevadans. And so as you can see in that gray box on the left, we still have 4 divisions at DHS. That's Children and Family Services, so child welfare remains with that department, Public and Behavioral Health, and Social Services, which was formerly Welfare and Supportive Services, and then Aging and Disability Services. Now the stars there that are there is because some elements of those divisions came over to the new Nevada Health Authority. For Public and Behavioral Health, what came over is healthcare quality and compliance, which a lot of you may know as HCQC, which is our licensing entity for facilities. They do inspections, they do a lot of other things around healthcare quality and safety in the state. That division, or that part of that division, came over. Also under the Division of Social Services, as Medicaid is moving into a new single state agency under federal law, that state agency is the entity responsible for Medicaid, so eligibility policy came over. We still work with social services and the division there to implement and provide eligibility enrollment, but we own the rules and requirements around that at the NVHA and work with CMS. Aging and disability services, the pieces that came over were really around our provider audits and other things that we need to do to have oversight of the home and community-based service waiver services that ADSD administers for Medicaid. So at NVHA, we have 4, I would say, new divisions. Nevada Medicaid, which used to be a long acronym, so Division of Healthcare, Financing and Policy is now what you may think of as Nevada Medicaid. We'll talk a little bit about some changes there, but when you are really thinking about DHCFP, that is the division. And then Consumer Health Services, we'll look in a minute at that, and then Public Employee Benefits Program, and then what we're calling Healthcare Purchasing and Compliance. When you think about the new health authority and kind of what we'll walk through in a little bit about our focus, one of the things I think that's really important to remember about bringing all these healthcare programs, which you can see at the top, Nevada Medicaid, Battle-Born State Plans, Nevada HealthLink, and PEB all together, you have nearly 1 million lives. It's almost 1 in 3 Nevadans. It's a large footprint that we have an impact on. And I think that's very important when we're working on streamlining healthcare requirements, making things easier for providers. We are having a larger impact when we're doing that together. And so that is really what we're leveraging is this footprint to be able to change healthcare in the state. With these programs, we enroll or contract with 1 and 2 providers, possibly all providers if you want to consider all the products in the HealthLink. 1 and 2 births in Nevadans. We already know Medicaid covers 50%, and you add in PEB and the qualified health plans in exchange, it's at least 1 and 2 births in the state. And also, when you put all these programs together, we are spending over $13 billion state and federal on healthcare. So we have a pretty large footprint. And I would argue a lot of buying power in the healthcare system, given the money that we are giving out to providers in reimbursement. This is our new executive leadership team. Some of these faces you may already know, some are new. So on the right here at the very top, we have what we're calling our senior clinical team. 2 of our main leads that are in-house are Dr. Keiko Duncan. She is our senior clinical and pharmacy officer. And then Dr. Keith Benson, he is our state dental officer. And then we have 3 new physicians that, 2 we've already gotten hired through UNR. We're working to get at least 1 or 2 more physicians that will be on contract with us through the universities that we're able to leverage Medicaid federal dollars, and the university puts up the state cost of that those positions. And so it's a real win for us as well as them. These individuals are helping us on a variety of policy issues. We have one who is a clinical informatics physician, which I didn't even know that existed, and he has been an amazing part of our team and is already diving in and helping us look at data in a way we haven't really looked at. So very excited to have the academic partnership that we've been building and working hopefully soon to get some UNLV physicians as well. Over here on the next column is the next row is our director's office. And so when you think of like maybe DHHS, there was the director's office. This is the director's office team. We have Lynette Aaron. Many of you probably have seen her at the table with me at IFC and other budget committees. She is our deputy director of healthcare financing. Before, when DHCFP existed as a full division, Nevada Medicaid budget was under that division. We moved that budget up because there's so much of the department that can be leveraging federal dollars, and she's really looking at maximizing that for the state in a way that is really supporting Medicaid and is appropriate under federal law. She's also managing still the rates and financial analysis, provider payments, and federal funding and reporting to the federal government. And then we have Allison, as I mentioned earlier. She's our chief of staff. She's over HR, communication. She's going to be doing all the legislative outreach. So if you need something, please email Allie. And she's going to be overseeing our Office of Analytics and the work around the APCD, the All Payers Claims Database. We'll talk a little bit later about that project. Sandy Rubalid is our Deputy Director, Enterprise IT and Innovation, and she is working on, a lot of her work before was only on Medicaid. Now her team is really supporting the entire department and making sure our IT, our cybersecurity is strong. And she's over a lot more, but I'll move on to Melinda. Melinda is over our community engagement and all of our workforce. She's our deputy director. She does our boards and committees that we have at the department. She's over workforce development, all of the new grants, which I know everyone's eager to talk about, the Rural Health Transformation Grant. Our Patient Protection Commission is right now with her, but is also still living under Consumer Health Services. So it's kind of been supported by Melinda as we're building up our teams. And then down below are the 4 divisions, so on the last row here. And on the left is Todd Rich. He was over our purchasing compliance. His last day was last Friday. Already missing him. He moved on to the private market, and very grateful for all the work that he did while he was with us to help us stand this up. He helped us get through session. So Cynthia Leach, some of you may know her. She's here today. She was previously over our Medicaid Inspector's General Office and has done a lot of work around provider enrollment, really making that a better process and automating that. She's been a huge advocate of, getting rid of provider fraud and waste and abuse, and has really led that area into success. So she has stepped into the administrator role as of yesterday. So I'll be replacing his picture soon. This division is over regulatory and compliance, purchasing and contracting, Medicaid Inspector General Office, provider enrollment, centralized credentialing, all falls under that. And then our facility licensure inspections and other things that ACQC did over before at the Department of Public and Behavioral Health. Jennifer Krupp is our administrator over the Nevada Health Link, the Patient Protection Commission, and also our public option, which is our battle-born state plans. Nevada Medicaid, our director and administrator of Medicaid is Ann Jensen. What still remains under Medicaid, our benefits and delivery system, which is our managed care program and fee-for-service, our federal policy and waivers, so all of our benefits are developed and maintained by this part of this division, community supports, all of our waivers, and long-term care. And Teresa Karsten, last but not least, is our Public Employees Benefits Program Executive Officer. She administers the PEB program and really manages those contracts and the PEB board. All right, so just to give folks a sense of who's under each division, because we've been getting a lot of questions and totally appreciate that. And I just want to say, I know our website is, I would say, could be much better. We're in the process of moving to a new platform, and we will be working to make that much easier to navigate. I'm very grateful for the Governor's Office IT team who's been helping us get that ready and up and going. On the left here, as you can see, Deputy Administrator Kyle Devine is over ACQC. He came over with the transition. I mentioned Cynthia earlier. Her position is now open. As well as a new ASO4 who will be doing all of our healthcare purchasing and contracting at the new division. We just posted that, and so working to get that position filled. Jennifer Krupp, I mentioned. Janelle Davis is our Executive Director of the Silver State Health Insurance Exchange. She was previously the Operations Deputy, and so we're very excited that she has moved into that role. Adam Plain, who came over from the Division of Insurance, is over our 1332 reinsurance waiver programs and as well as our public option. So he's managing all of those contracts and setting up the new reinsurance program with DOI. And then Dylan Mamlov, he is over our Patient Protection Commission. And then Anne, under Anne's team, she's got 2 deputies. Kirsten Colomb, who used to be the chief over the waivers, has now moved into the deputy administrator. She's over all of our waiver programs like she was before, as well as the district offices, who do care coordination and really help people who are having struggles transitioning to care. She's overseeing those programs. Just as of yesterday, Jimmy Loud joined our team. He came to us from the healthcare government relations world here in Nevada. We're excited. He is going to be over benefits and delivery systems, so managed care program, all of our benefits. He'll be overseeing medical and behavioral health and dental. Our agency manager is Casey Angers. She's over our federal policy and all of our waivers. And then Tanya Stevens, who came over with the Division of Social Services to run eligibility policy for Medicaid. I think Public Employee Benefits Program looks a little bit the same. Nick Proper is still our operations officer, and Monica McJoy is actually new. She's our new CFO at PEB, and Leslie Biddleson is our quality control officer. All right, so we'll dive into the mission and strategic priorities. So we tried to come up with a easy slogan, and I'll tell you, for those of us that work in healthcare, we're very much jargony, so trying to avoid jargon, but you can't help it. Our vision is a healthy, thriving Nevada where healthcare is affordable and reliable. I really think that last word, reliable, is super important. We can make healthcare coverage affordable all day. Everyone can have insurance, but if they can't get in to see a doctor when they need it, then what's the point, right? It has to be reliable. So that's really, I think, something we're going to really focus in on is what does it mean to have health insurance and make it reliable to access care. Our mission is to meet that vision. Our mission is to really work on leveraging our buying power, that footprint I mentioned earlier, to get the best deal and value for Nevadans, streamlining our programs where we can leverage each other's resources and align even requirements with our providers so it's simpler, and hopefully drive better quality and innovation in our healthcare system with that footprint and all the things that we're trying to do and implementing them consistently across all of these markets. Our values we've outlined are really public service, obviously, is really important to all of us and our team. Fiscal discipline is vital to the work that we do. Program integrity as well, transparency for the public, and just really that accountable leadership. So we've outlined 4 goals. I mean, I think it's hard to really narrow it down to 4. There's so much that needs to be done in healthcare. It's one of those systems that feels like there's always work to be done, but we really focused in on 4, and I think they align a lot with the statute that was passed, the bill. The first one is obviously healthcare improvement. On the right here, you can see our scorecard. This is for 2024 and 2025. I know when I usually present this, someone always reminds me that they've been here a long time and they've always been in the bottom 10. So, but I would just point out, we're not just in the bottom 10, we're at the bottom. That's not okay. We're spending over $13 billion on healthcare services, and we're 51st. We're beating Mississippi for 51st. And I'm from Arkansas originally, so I feel like I can pick on Mississippi. But the fact that we are now 51st says something. We are not doing what we need to be doing in the state. So that is something we're taking very seriously and trying to look at what can we do to move the dial, right, and move up out of the bottom 10 on these areas. And we're really focusing in on, I think, specifically chronic disease management and prevention, maternal health, obviously quality of care and safety of care, and then mental and behavioral health, substance use treatment, trying to ensure that we have access and better outcomes. Number 2 is program viability. We can do all this work and make everybody happy and increase rates all day, but if the program isn't sustainable for the budget, we've also failed, right? So that is really important that we do this work with an eye on what does it cost us and what are we getting for the very limited revenue dollars that we have in this state. So really having economic resiliency for our coverage programs is very important. And then 3rd is healthcare workforce capacity. That goes back to that reliability. We all know we have a healthcare workforce shortage. I know we're not alone in the country with that, but I think this is really key to making sure that our coverage is reliable for families. Luckily, we've got 2 new grants on the table. One was passed by this body, Senate Bill 5, the SHARP Act. So thank you guys very much for that funding. It's about $60 million, which can help go into workforce efforts, as well as the Rural Health Transformation Grant. So we're very grateful to have those opportunities to help with this goal. The last one is value and innovation. We're really looking at how do we use our programs. So for those of you that may not know, for most of the programs that we oversee and manage, we have contracts with the providers in some way, as well as the carriers. And there are ways that we can align those and incentivize value and innovation that if you do that across markets, actually has a bigger bang, right, for the buck. And so those are things that we're going to be looking at over time and how we do that across our programs. All right, so let's dive into health improvement first. So I mean, there's a lot of other stuff. I just want to say too, we picked a handful of projects. There's a lot of other things that we are working on, including just standing up, like adult dental is a big one, right? And some of the other projects. But I wanted to highlight some things that we've been working on that I think many of you are familiar with to give you an update on them. And then obviously at the end, if there are other things that you want to know if we're doing or that was missing, please ask, and we're happy to talk about. Healthier Nevada Schools is an initiative we've been working on, especially Deputy Director Melinda Southard, prior to NVHA's establishment. We've been doing a lot in the space of trying to understand what our schools are billing for, why they aren't billing very much, and how do we make it easier. We have a new pilot thanks to a federal grant we got, I think it was a year and a half ago. It feels like yesterday, but Melinda and her team have been working really hard to get a pilot vendor up and going with to offer billing services to schools, because that is often what we hear. They don't have the time or the capacity or even the electronic health record they need to do what they need to do to bill. And so what if we provided them that vendor that they can connect to, maybe we can get a better deal on that for them as a whole, as a state, and they can actually start to bill us, especially for behavioral health services. We cover a lot of services in schools, and what we're really primarily seeing and have been seeing for years is just the basic mandatory services that they have to provide for disabilities, which is great. But we want to see them billing for other things, right? The preventative services, the screenings, and the behavioral health care that we know students need. So those are things we're working at. 4 local education agencies, which are our school districts, will participate in the pilot, and then we'll be expanding it to all schools in the 26-27 school year to use the new vendor. We're going to see how this goes. If it goes really well, we'll probably be bringing it forward next session to look at ways to fund it long term. So we can ensure that schools can continue to bill for these services. We also developed a new user-friendly Medicaid school health services manual like other states have that really helps schools, because often they go to our billing manual and it's written for a healthcare provider. Schools are, they're not always healthcare providers. They're teachers. And often other people that work there, maybe they are healthcare providers, but they don't have time to go through all the details. And so trying to make that simpler and easier was a really big task, and I think we've done that. We also set up a school health access resource center and a steering committee. And that committee has really played a big role in establishing the billing vendor, giving us feedback on a lot of our work around how schools are billing. As well. There's also a medical billing technical assistance effort that we're doing with the Department of Education, but our Medicaid team has a monthly training and office hours with schools. We hop on. If anyone wants to hop on and ask our team questions, they can. If they don't, they don't. But it's a way for us to have a door that they can access, because often what we hear is, I emailed the inbox and never heard back, right? So how do we make sure we have a door open for them? So that our team has been doing that monthly. And then we're also looking at really behavioral health and working closely with UNR, also the Division of Public and Behavioral Health, and Department of Education on how do we implement best practices in schools around behavioral health, because we know that's a big challenge for our schools. Statewide Medicaid managed care was effective January 1. Yay. We are up and going. Very proud of that. I think we were always holding our breath when we start something new and go, especially statewide. For years, for those of you that may not know, managed care delivered and pays for services for years just in Washoe and Clark County. This expanded it to statewide from the last session. This was passed in 2023. It took 2 years, as you can see, to get that stood up. And we did use a competitive procurement, and we had several key goals that we outlined, right? Really making sure that we had adequate service areas, network adequacy, access to care, member and provider experience was really important, especially in our rural areas. We did a rural hospital tour, which was really, I think, valuable to us and our team, myself. Understanding what our rural communities really are going through and struggling with was really powerful. And so when we built this, we wanted to make sure that they had choice in a health plan, but they weren't overwhelmed with their options. So we really narrowed it down to 2 in the rural counties, because no one needs 4 or 5 contracts and all the negotiations that go along with that. So we picked our 2 top performers in rural. And as you can see, that was CareSource, which is a new nonprofit health plan into the state. And then Silver Summit Health Plan was the other rural healthcare provider or carrier. We also focused in on care quality and outcomes. Federal law requires us to have a quality strategy. That obviously is part of our efforts, but we did a lot more. We are requiring value-based payment design, community reinvestment dollars, and a variety of other initiatives to ensure that there is a focus on building up infrastructure so we can have quality and better outcomes. And then the other piece is just population health was a big piece of our procurement. So as you can see here, and sorry if it's a little confusing, in that peach box at the bottom are the 2 rural plans. As you can see, that's the rural service area. These plans are also in, as you can see, our urban Washoe area as well as urban Clark. Urban Clark area only has an extra plan, which is in that blue box, which is Health Plan of Nevada. So as you can see, that means that Clark County has 5, and according to our consultants and our actuaries, 5 plans make enough, or it's okay to have 5 plans given the size of that population. We did not want to go beyond 4 for Washoe given the size of that population. All right, Children's Behavioral Health Transformation. This is being led by
Director.
Oh,
Director
go ahead.
Weeks.
Yeah, sorry.
Thank you so much. If you don't mind, can we just pause as you go through each one of the programs to make sure that we don't have questions? The information that you're providing is really robust, and I just want to make sure that we have a clear understanding. Thank you. Can you go back to the Healthier Nevada Schools? I just want a little bit more clarity around where we are relative to that piece. The local education agencies, I believe you stated, are the actual school districts, and there are 4 of them that we're currently considering to launch this pilot. Is that correct?
Madam Chair, Stacey Weeks for the record. I'm going to defer over to Deputy Director Melinda Southard so she can answer these questions.
Madam Chair, members of the committee, Melinda Southard for the record, Deputy Director at Nevada Health Authority. So yes, the local education agencies include all school districts as well as the State Public Charter School Authority. And we are having an application process that's actually going on right now for all the LEAs to be able to apply to participate in this pilot. So we will be reviewing those applications and letting the 4 LEAs know as soon as we can on if they've been provided that opportunity or not.
Thank you. Do you have an anticipated time frame for when that approval process will be completed?
I do. Sorry, Melinda Southern for the record, Madam Chair, members of the committee. Yes, so today we are reviewing all the applications that have been received. I believe we received 10 or a little bit more than that, which is really exciting for this new program. And so we'll be reviewing those today. And I believe, I want to say within this month, we will be awarding or notifying the 4 LEAs.
Thank you. And then as you progress through this pilot program, you will be working on the billing, right, as a state agency, or will each of the school districts that are in the pilot be billing directly?
Madam Chair, members of the committee, Melinda Southard for the record. Yes, so all of the LEAs will be working with the vendor. The vendor will provide the electronic health record system as well as Medicaid billing components to that. So the LEAs will be able to bill Medicaid through that vendor.
Thank you for that clarity. I missed the vendor piece of it, so that makes more sense to me at this point. Thank you. And then there is a steering committee that was identified. Can you talk a little bit about who is identified to be on the steering committee?
Madam Chair, members of the committee, Melinda Southard for the record. Yes, thank you for the question. So the steering committee, we wanted to have a wide variety of different individuals who are associated with schools and school health services. So we do have members on that committee from the Nevada Department of Education, as well as urban school districts and rural school districts. We also have members of the Nevada Health Authority that are on that committee that help to manage and facilitate the committee. And we also, sorry, apologies, have members that are participating from UNR, multi-tiered system of support office. So we do have a wide variety on that steering committee, and they've met quarterly to provide input and technical assistance to Nevada Health Authority on, what components that we're looking for in a school electronic health record and Medicaid billing vendor support, and what different types of technical assistance would be most helpful for the schools, and just really providing that, sounding board so that we could write a generally, a well encumbered request for proposal for that vendor.
Thank you for that clarification. And then one final question from me before we go to the rest of the committee. I'm curious to know about parental involvement relative to the delivery of a medical service at the schools. I know that that has come up at times in the past, right? How do we have a parental authority as to what types of treatment kids are receiving in the schools? Can you just talk that through a little bit?
Madam Chair, Stacy Weeks for the record. I think that's a better question for Department of Education to probably answer. We can follow up with them. Usually there's, they have to provide consent. I just don't know all the details. I think the Department of Education does that part, but we can follow up with you on that. We just pay for the services once they're provided.
Thank you. Thank you for that clarity. Members, any other questions relative to Healthier Nevada Schools?
Madam Chair.
Senator Titus.
Thank you. So thank you. And thank you, Madam Chair, for stopping at and going back to the Healthier Nevada Schools. My question is in regards to the pilot programs and the identified education, what do you call them? The 4 different schools that you're going to identify. Is that school districts?
Madam Chair, members of the committee, Melinda Southard for the record. Yes, LEAs include school districts as well as the State Public Charter School Authority.
Okay, thank you for that clarification. And then it's a discussion I've had for a long time regarding Medicaid billing. And I've spoken to the Superintendent of Education, I've spoken to you, the Medicaid offices. It's a true issue, and the schools and their funding issues and concerns, they could be gaining a lot more funds if they bill properly. I'm concerned about the delay in a pilot program when every single school district has these issues. And what I was led to believe when I've met over this issue is that the Department of Education was going to look at hiring billers to help all the districts perhaps bill Medicaid. And now I'm hearing you're doing a pilot program with only 4, when I know, because I actually serve in a capacity for Lyon County Schools where I do their special education reviews, sign those charts off, and they don't bill for my services, and they should. It's current, it's happening now, the money is lacking, and I'm actually discouraged to hear that instead of getting something actually done, we're going to do a pilot program. So tell me how this actually accelerates what the issue is today, where it's been years where they haven't billed it, and now instead of helping them with billers, we're pulling out only 4 schools or 4 districts to get the billing done, leaving the others behind. And then what's this process here? So I'm a little disappointed.
Stacy Weeks for the record. Thank you for the question. When we got the grant, CMS really pushed us to do the pilot first to make sure we test it with schools that we thought were ready. It's only a year of a pilot, and then after that, it will be open to all schools. So it's a grant that we're following the federal requirements, but once we get through the first year, we test out any, kinks, but to have all the schools, if there's any issues, would be challenging. We wanted to really focus in on 4, make sure we get all it right, and then expand it out in a year.
Thank you for that. Is there anything that stops the school districts from, the issue is personnel and hiring the people that it takes to do Medicaid billing. There's nothing that prohibits schools from going forward if they had the capacity to bill now, correct?
Madam Chair, Stacy Weeks for the record. That's definitely correct. We already have schools billing. I think this effort is to really help those schools that tell us every day, even when they hire someone, they're still struggling. So no, today schools should be billing us, and as you said, they just don't. And so we're trying something some states have tried, like Arizona and others, that has been successful. But to get this grant, this is sort of the process that we went through. Thanks to this grant, if it wasn't for the federal grant, we probably would be coming next session to do this. So it helped us get started quicker in this process.
All right, I like the word start. I like the word quicker. And I like that it's within a year we may be seeing a difference. Because this has been going on decades, and it's not a new problem. And what we have done, what is new, is that we've actually identified, hey, here's something you should be doing. And to your credit, you have said, hey, why aren't you billing? This is something that you should be picking up on. So thank you for doing that. I need to see some results.
Madam Chair, Stacey Weeks for the record. I appreciate that, and we need you to push. I mean, honestly, I wish sometimes we could move faster, but I promise you, we are trying our best. This has been a big, high priority for us, so thank you.
Thank you. And I would just like to note, I do believe that was one of the measures that we did work on last session that we were not able to successfully get through. So know that this committee has been working in a dedicated effort to move that direct billing to schools so that we are drawing down additional federal supports. With that, we will go ahead and move to our next question. Assemblymember Goulding.
Thank you, Chair. For a point of clarity, are the services that are provided in schools only available to students who are Medicaid eligible, or are they available to all students?
Madam Chair, members of the committee, Melinda Southard for the record. Those services are available to all children, regardless if they're enrolled in Medicaid or not.
Thank you. Okay, next question. We have Assemblymember Nadeem.
Thank you, Madam Chair. Thank you for the presentation and thank you for making it so clear for every one of us. My question is regarding the statewide managed care rollout. Is that the insurances it has is like Health Plan of Nevada, Molina, Silver Summit, Care Source, and couple of other. So they are, how will that go? These insurances are independent identity, so entities, so they will be included in the state managed care rollout, or the billing, how the patient will get those insurances and how the billing will take effect.
Madam Chair, Stacey Weeks for the record. So we already have managed care today. It's a way that we pay for, deliver the we don't directly deliver healthcare services. We pay for them, but we help build. One of the things that managed care plans help us do is build a network. They manage that network. They do all the claims review. They do all the prior authorization. They help us pay for those services in a way that we can't, as a state, hold the capacity to do that. They do other things too, but that I think at the basic core. So just like they do today, anyone who is a managed care recipient in Medicaid, so maybe I'll back up there. The people that are not in managed care today or that won't be in the future will be anyone who's part of is in a disability bucket or age, blind, disabled, and on a waiver. Those folks will be still fee for service. So for example, they don't have they have access to the network, but it doesn't mean we've done all of the quality and the network adequacy and all the things that managed care plans do. But they can still get Medicaid, but the provider bills us directly and we pay the provider. And we do manage that work. The other population right now is a child welfare population. That would be fee-for-service. Katie Beckett, which is a buy-in program for disability families who make too much to qualify for Medicaid. And also just our senior population, I mentioned, the age, blind, disabled. They will be outside of managed care and anyone that's on those home and community-based waivers. Everyone else, so all of our families, adults, parents, adults without children, pregnant women, today in Washoe County and Clark County are on managed care plans. They each choose a plan, and that plan provides benefits to them that we cover. And so the providers will bill that contract with that health plan to bill for those services that Medicaid pays for. So that's the way it will work in the rural areas, except they will only have to contract with 2 carriers, or if they want, they can contract with 1. Hopefully they've all worked these things out. I think they have. We met the readiness review. But in the rural areas, it will be similar. The only thing different, I would say, in the rural areas is that there are a lot of what we call directed payments to protect providers, like our critical access hospitals, our rural access clinics. Some of those entities under state law have what we call a directed payment, which means the health plans cannot negotiate a rate below what we would have paid fee for service. So it's a way to protect them in terms of their cash flow. And so going to fee for service isn't going to result in less money for them. That was the goal, to preserve that infrastructure, which we know struggles in the rural communities. So hopefully that answers your question. Happy to dive in more if you need it.
Yes. No, thank you so much. Here I have one more question. Thank you so much. So my question is regarding the Medicaid. As I myself deal with, I'm in healthcare and deal with the patients and the providers. In the last 1 week, we saw there were 5 patients on Medicaid, but they got ineligible and they did not know about that. So I want to know that how your department is helping them in knowing that they don't have, they don't qualify for Medicaid anymore, and what they can do to have another insurance.
Stacy Weeks for the record. So right now, we currently, there's another slide in the future. Hopefully we can talk a little more about eligibility and enrollment. We currently contract in an interagency way with Division of Social Services to do enrollment and outreach. So typically when someone is disenrolled, they get a letter and information about how they can find other options. Now, I'm not going to say that all the times individuals that we send these letters to get them. I mean, that happens. It's a transient population. A lot of things happen where they're not always getting the information. Some of the new modernization efforts that we're trying to do through our exchange for this population, which is a very modern platform, automated in real time, I think will be a really great service to individuals in that situation. Because not only will they get a notice, but then they can go through the same entity that they got their Medicaid through and find a health insurance plan that they can qualify in the private market. We also have navigators under the health authority that we're going to be, with the, thanks to the grant that this body approved during special session, we'll be helping this population as well who have maybe been disenrolled connect with private health insurance through the exchange and get subsidies. Often they're eligible.
Thank you so much. Thank you.
Thank you. Senator Danyate.
Thank you, Madam Chair. I had a question regarding Ms. Weeks on the slide dealing with the statewide Medicaid managed care, to continue on the questions on that. I was reviewing last week the report that was published under DHHS, which is the 2025 through 2027 Quality Improvement Program that Medicaid was implementing. And one of the two things that I mentioned was a goal targeting on STAR improvement ratings and also on network adequacy. So my first question is, with CareSource coming into the market, how are we monitoring network adequacy for them specifically? And the second question, to finish off that first one, sorry, both for the new market player and also for them entering into the rules. And then following on to that, what efforts are we going to start implementing to make sure that we are holding MCOs accountable for their lower STAR ratings or their decreasing STAR ratings?
Committee member Stacy Weeks for the record. Those are good questions. The first one is around CareSource. So under federal law, there are a couple required quality efforts that we have to do, and what you refer to as the QIP, the Quality Improvement Program. I'll be honest, every state does those, and it's unfortunate, but we don't usually see an uptick in that area. It's often when we put incentives tied to something, we see changes, or require value-based arrangements with their providers. So what we're trying to do in the new contract is really tie what we're calling a hospital. We're starting with the hospitals because we know that they serve a lot of individuals in the state. We're starting with what we call a quality collaborative. And that quality collaborative is really focused in on improving some of these metrics. When it comes to CareSource specifically, we use an entity called HSAG, H-S-A-G, and they, federal law requires that we have an independent external review organization that monitors and assesses on a regular basis our network adequacy standards and does all of our quality independently of us and the managed care plan. So they kind of really are that check. We send those reports that you're referring to and other reports to CMS as well that reviews that for us. So at this point, we had a few months ago is what we call our readiness review, which is required when you're standing up a new contract period, and you want to make sure all the plans are ready, that their new networks are working, that they meet all the requirements, and that there's no gaps, right, for recipients of those benefits. And HSAG and everything has gone well. Like, we wouldn't be sitting here today saying it has been implemented if those readiness reviews were not met. So right now we can say that we have met that. We will use HSAG like we typically do with CMS to monitor progress. We are having monthly calls, and as well as there are going to be some efforts where we are going to encourage, especially in our rural areas, that our managed care entities go out and do another rural tour at least halfway through the contract year, because what we have found, it is those relationships that are really important in face-to-face conversation about the issues that they're experiencing. I will say that I don't want to pick any plans and say there's any favors because we don't really say that. But I will tell you, I have gotten amazing feedback about CareSource from multiple providers and their contracting process. So right now, I'm feeling pretty good about where we stand on that, but we will be monitoring them carefully. And then when it comes to generally the MCOs and the quality metrics, we do have a quality withhold. We probably will need to really look at that opportunity in our contract as a way to penalize or reward those that are doing better or worse. I think in the past we've waived some of those because of COVID or because of other issues. But I will say that we are looking at those quality metrics and definitely want to make sure that they're getting better. I think the quality collaborative is important, but MCOs alone can't fix this problem. We need our providers to come to the table and be a part of quality. They provide the service. So it's not just on the MCOs, which I appreciate, we pay them a lot of money. But I also, that's one of the reasons I'm very hopeful about this hospital quality collaborative, because I think we do need those larger healthcare providers at the table to improve quality too.
Thank you. Thank you for pausing and allowing questions. Okay, seeing no other questions. Okay, we're ready to move on. Thank you so much to Children's Behavioral Health.
Okay, moving on. I'll stop at each slide. Thanks for stopping me. I needed a breath too. All right, Madam Chair, Stacey Weeks for the record. Children's Behavioral Health Transformation Project. This was really in response to, I think many of you have heard us talk about this, Ann and myself, as well as former Director Whitley and others, is the Department of Justice settlement agreement that we entered into over a year ago. And the issue here was the DOJ came in and did an investigation into a complaint that they received that we were institutionalizing children unnecessarily who had behavioral health conditions. And as you guys may remember, under the Americans with Disabilities Act, we are not allowed to just institutionalize anyone just because they have a disability. We have to do our best when we're providing public programs to ensure those public programs cover and offer home and community-based services. So when the DOJ came in and said, we can either go to court, right? That's usually the threat, or we can come to a settlement. So the settlement agreement really outlines a set of services that we have to stand up in Medicaid and cover, really trying to build out new provider types that will really help these children and and their families and their parents and guardians, support them in the community setting. So they don't have to go into what we call a psychiatric residential treatment facility, which I think some of you at IFC recall the PRTF that we were talking about, right? And then also in inpatient psych hospital setting, trying to avoid those higher level institutional settings for the home and community services. Often there are some kids that still need that treatment, and that's okay. But our goal here is to make sure that it is only available, only the kids going in there do need it, and that they're not there forever, that they're not staying a long periods of time, or they're not coming out and cycling back in, right, or into juvenile justice system, which is often another area where this population can sometimes go. So we have been working on a couple things. I would say it's really a three-pronged approach, right? So what benefits are we missing? Let's get those added. We are getting, I think we have submitted a lot of state plan amendments. I love to blame CMS actually, but I hate to always use that as an excuse, but we are waiting on a lot of things right now from CMS, but also they most recently have been responding. So we're excited that maybe we're getting closer to some approvals. But a lot of these benefits will hopefully be coming online soon. We do have family and youth peer supports, I think, up and going. But we do want to get planned and emergency respite approved and start paying those services. We also have rate increases that we have put into place a lot for our PRTFs, so we can actually support their ability to hire quality providers, right? So rate increases hopefully are going into ensuring that there's quality care. We also did rate increases for individual and family therapy, as well as psychosocial and rehab services. Some of those are pending and some have been approved. A lot of them will be backdated, but we're still in the process right now of working with CMS on that. The third item really is the delivery system. Right now, it's a fee-for-service program. Our care coordinators do an amazing job at the district office, but they cannot, and neither can the counties, I think at times, manage the workload of this population. It's a difficult population to find services for. And so what we're standing up is what we're calling a specialty managed care plan. It'll be one plan that's dedicated to this population to ensure that they have services available in network, and that they're making sure that every family has what we call like a wraparound facilitator that goes in and supports them if they are willing to let that person in. There's also some families that do not want you in their business, right? And so we also have to figure out how do we help families in their home under the DOJ settlement agreement in a way that's respectful and comfortable to them. We are currently trying to get a federal waiver to finish this process. We did issue the procurement recently, so that's up and going. So we can't speak to the plans yet, but hopefully we'll be making those awards sometime this year. It will be effective 1/1/2027, and we are definitely working closely with CMS to get all the authorities we need to get this going. And like I mentioned, our PRTFs, not just on the Medicaid side, we're looking at what I mentioned, the licensing and inspection side, just given some of the things that have happened recently in the Mariah Ignite facilities. We are really going to be taking a hard look at what do we require, how often are we going out, and do we need more clinical expertise on some of these teams that are going out and ensuring that kids are getting actual treatment in these facilities, and that they are safe and they're getting better. And so also the last piece that's really important, I think, is really holding them accountable too for their actions when they are not taking care of these children. So that's something separate from the Medicaid side that Cynthia Leach will be working on with Ann. But this is a big project, and I'm going to stop here, Chair, because I'm sure there's some questions, so I'll just open it up here.
Thank you. I appreciate that. Members, questions? Okay, I do have a couple of questions. There was a period of time where we had a number of youth that had to receive services out of state, and we were working diligently to bring them back into appropriate services within the state. Do you have a current count on how many children we're serving that are perhaps still out of state?
Madam Chair, committee members, Ann Jensen for the record. I'm the administrator of Nevada Medicaid. We can follow up with the exact number as of today. This is something that our team monitors on a monthly basis. I can confirm the total as of January 1st was 330 children in total. And of those, I believe it's about 40 that are out of state, but we'll confirm what that looks like, including our most updated numbers as well.
Thank you, Ms. Jensen. I appreciate that. And then there seems to be some concern regarding a delay in assessments. Do you have any data around how long does it take for a child to get assessed appropriately for this type of service?
Madam Chair, committee members, Ann Jensen for the record. Yes, that's actually a data point that we're held to as part of the DOJ settlement agreement to analyze on a quarterly basis and share that with both the DOJ team and our independent reviewer. We have a new public dashboard that is available with some additional data points. And so what I will tell you right now, though, is that we do not have a standardized assessment process in the state. And that's part of what we're held to do in the settlement agreement. So what we can measure as of right now, the time between when an assessment is billed and when services are initiated. And that's something we've been tracking for the past year, and we can confirm with you how that's trended during that time. However, I think there's a significant opportunity, as you're noting, to both decrease that time and also look at the process to get the assessment, right, before that process even begins. And unfortunately, that's not data we have right now, given the assessment process. I'm really thankful for our clinical team that's working to develop that assessment process with the support of DOJ and our independent reviewer. We actually have a summit on Thursday of this week with providers from across the state joining to talk about the screening tool component of the process, which is really step one. And then step two will be that assessment tool and system development process. So lots of work to come on that. Happy to provide additional detail as is helpful.
Thank you, Ms. Jensen. And then one additional question for me at this point. Director Weeks, you talked a little bit about the Mariah situation that came up during the Interim Finance Committee in particular. While we as a state don't license them, as from what I understand is that you all have done oversight and we are not as a state sending kids into that care setting. Is there a way for us to identify the number of kids that don't come through our state systems that will refer to a behavioral health home such as the Mariah facility?
Madam Chair, Stacey Weeks for the record. So we do license PRTFs. The issue is they don't just take Medicaid. So, I can look at claims data, I can pull, but also claims data doesn't tell me real time who's there. They are supposed, our requirements require them to have up-to-date medical records, so we should be able to. The issue has been whether or not they're complying with the requirements that we have, and I think that might require harsher penalties, and us providing more regular overview and oversight, and that's going to require staffing and also maybe additional contractors. And making sure that our team feels equipped to assess those records too, so that maybe where the clinical expertise needs to come in. So we do license them. I think when it comes to tracking children, the issue is we do know there's some cash pay, there's private pay that we know TRICARE sends kids to all these insurers send kids to these facilities, but we don't really track that, right? We don't have that process, and that's probably something I think we're looking at. Do we need something with even the Division of Insurance? Should we be reporting to them so they can tell the insurers that are in our market that this provider maybe is not a good provider, right? Because we can pull out of that provider, but whether or not they close their doors. And then the other issue is providers operating without a license. And that is another issue that we're going to have to tackle. And it's going to require probably law enforcement, to deal with that. And I think that's something we're going to have to bring to this committee and next session.
Thank you for that. I know that there has been a significant amount of work that's been done relative to just the safety and welfare of children who have high behavioral health support needs. And so I appreciate the dedicated efforts relative to protecting our children and the families that are supporting those kids, right, as they move through youth into adulthood. Members, any other questions? Go ahead.
Thank you so much, Chair. Thank you so much for answering the questions. And I want to go back again and again to the Medicaid, because what I have seen and what I am experiencing, I'm really worried about it, about the Medicaid cuts, and it's how it's affecting the patients and the people. So I want to know that with the new Medicaid benefits and rate increase, it says that it will be supporting the behavioral health and pending federal approval effective no later than 1/1/27. And the new facility managed care, that is for the behavioral health, children behavioral health, requires additional federal waiver effective 1/1/2027. So what will happen? And the patients and the people who are the community members who are on Medicaid services and cannot pay for the private insurances as the premium are increasing. So what they are going to do in between?
Madam Chair, Stacey Weeks for the record. I'm going to take part of the question and then hand it to Ann to talk about what really has been already implemented and some of the rate increases that we can provide or should be able to provide before 2027. So I just want to say hope is on the way, or relief is on the way. We've just been kind of holding our breath with, I think, the federal shutdown, all the things that have been occurring. You asked a little bit about, I just want to clarify, there are no Medicaid cuts right now. And I have deep concerns about us with that message. Because I don't want people to think that they cannot get the care that they need. Anyone who is disenrolled right now is disenrolled because they're ineligible under the same rules that have applied since last year and the year before and since the ACA. Work requirements and some of the other changes are coming in 2027. So that is when we are going to have those conversations, I think, in this committee too. I know the chair wants to talk about these changes, but I just want to be clear right now because I want to be mindful of the narrative that scares a lot of people. And I just want to be careful that we're not saying that Medicaid right now is cut, and I want people to know they can still get their care. So I just want to say that. And I know there's a lot of confusion about HR 1 and what it means. And then there are some funding changes. They will happen to hospitals, but not a lot. Many of them are not directly to our budget. And so that is, I know that doesn't maybe give you relief, but it is good news to some of us that manage the program because I'm hopeful we don't have to make big cuts, So those are the things I just want to start out clarifying. We are working really hard, though, to get these services going. And I think it would be great if you want to reach out to Ann and me and we could sit down and kind of talk through what you're seeing on the ground. Because sometimes, we only hear these things, they bubble up. So I would love to understand, too, where we can maybe do better and giving your patients resources to help them when they are experiencing a change between Medicaid and the private market. You are right. private market does not cover a lot of these behavioral health services and or doesn't cover them the same way in a way that's affordable for a lot of these families, and that is a struggle. And so unfortunately there's nothing that we can do at the NVHA around that, but those are challenges I think that all families that go off of Medicaid into the private market face, unfortunately. I'm going to turn it over to Administrator Ann Jensen to talk through some of the rate increases and timeline there, if you don't mind, Ann.
Absolutely. Madam Chair, committee members, Ann Jensen for the record. Happy to provide an update on all of the rate increases and benefits coverage changes, which I'll admit predates even my time here in the Medicaid division. It really began in spring of 2024. Thanks to Director Weeks' leadership and the team's work there, they were able to secure funding through an interim finance committee that was held in April of that year. And since that time, our team has been hard at work to get these changes submitted to CMS and approved as quickly as possible. As Stacey has mentioned, we've spent a lot of time with that team, and they have been really appreciative of the partnership and collaboration. But with a transformation this significant, it does take time for them to really review these items. So we have a total of 4 significant rate increases that are currently pending with CMS. Those will be effective retrospectively back to January 1st of 2025, which I know is over 12 months ago. We actually submitted our request to CMS for those changes in fall of 2025. So over 13 to 14 months ago. And there has been significant back and forth with CMS on all of these items. It's not that there isn't work happening, it's just a long process. And so I know that our providers are eagerly waiting those changes. Please know that we are working hard on our end, both to be as responsive as possible to CMS's questions, but also to get all our system changes and updates in order, so that way as soon as we get that federal green light, we'll be able to turn things on in our system and recycle the claims and be able to pay things at that higher rate. For some of the services, like our inpatient psychiatric hospitals and our PRTFs, we've been able to offer letters of agreement in situations in which that increased payment would facilitate access or higher quality care for our patients. So please know that we're working very closely with our providers to ensure their needs are met in the meantime. For the new services, so this is things that we do not currently cover but are happening in our state right now, and so providers would be accessing a new funding stream. We're in the process of what is really a multi-year endeavor to get Medicaid coverage for those. As Stacey mentioned, we were really thrilled to celebrate when family and youth peer support were covered, and we received that from CMS back in August of this year, and really grateful for our community partners and Nevada PEP's strong efforts to make that process happen. I recognize that's been over 2 decades in the making. So we did take a moment to celebrate before we started the hard work of really implementing it and getting folks enrolled and billing in our system, which is a significant process, and I can appreciate folks that our providers on this committee can speak to that. So the other new benefits, we are still working through the process with CMS to get coverage for, things like respite care, wraparound care coordination, updates to the way that we pay for mobile crisis. All of these things, we're spending time to do it right, but also moving as quickly as possible. So happy to answer any specific questions on those, but hope that overview is helpful.
Thank you so much.
Thank you. Next, we have Senator Titus.
Thank you, Madam Chair. Oh, so many questions. Thank you. So I appreciate you taking the challenge as we're going all over the place with these questions as you do your presentation. I want to first acknowledge and thank you for the clarity, Director Weeks, and making sure that we keep the narrative accurate, that nobody's losing their Medicaid at this time. And I think that's critically important. Now, do we have to deal with it in the future? Absolutely. That's why we're having these meetings and this discussion. So thank you for being in front of that. Having said that, I have some questions back to the inspection and the licensing of facilities. It's been in national news. Some facilities run from perhaps folks from out of the country having medical facilities that there's nothing there. And a reporter brought this up. It wasn't because somebody inspected these places. I'm curious about Nevada. I know that it takes personnel, and I know that you don't have enough. But when you license a facility, how often do you inspect it? This committee had to deal with in Reno child care facilities that needed fire inspections, and they couldn't get them done. I mean, it's a huge issue on the follow-up and documenting that you've licensed this building. Do they even have any patients there, or what is the deal? So how often do we in this state make sure that these facilities actually exist?
Madam Chair, Stacy Weeks for the record. I definitely know what you're talking about from the videos and have seen that. And I think we were just talking about that internally. I know with Cynthia Leach moving into the administrator role, one thing we're thinking about, and same with even just, are they keeping the right medical records? All the things that they're supposed to be doing, are they doing it? And there's a challenge, getting out. And I will follow up with you, if that's okay, by facility type, how often we are required to go out. My understanding is often we are in, like, for example, the hospitals, the skilled nursing facilities, and sometimes the PRTFs on a regular basis because of complaints. We are supposed to go out. But I think the challenge really is a lot of it's workforce. But will we ever have the workforce we need to be, like, watching every provider? There are a lot of providers. So one thing we've been thinking about, or at least I've been noodling on, is the all payers claims database. We can maybe track actual claims data, and we can maybe notice when a provider has some anomalies and whether or not they're billing or are they billing. There's ways to do that. And then also, can we hire contract staff, for example, more on a interim basis to go out on these facilities. So I think what we're going to have to do internally is look at, is there a better way of looking at data? Because we cannot be everywhere all the time. And people, unfortunately, that do these kinds of crimes are very clever. And, but are there ways that we can be looking at data, not just Medicaid data, but private data too, from the all payers claims database to see any trends and some providers who are not billing, for example, or any anomalies. And often that's where we're catching fraud. And we just got an amazing new system for Medicaid. And I can tell you, it catches any anomalies, like, outside out of the norm. All of a sudden we're billing for a lot of prenatal vitamins for seniors, men. There's like things like that we can kind of catch. But when it comes to like having empty facilities, I think it is going to be the challenge of, do we supplement our current workforce with contractors? But yeah, it is something I think every state is definitely like, oh no, are we doing enough? But it's a challenge to keep up with the fraud.
Well, thank you. I know you do a good job at long-term care, because as I was the medical director of long-term care for decades, we saw you, I think, sometimes too often. And so, but I want to thank you for that. So I appreciate what you're doing.
No. Thank you, members. Any other questions? Thank you. I'm just going to round back out to the original question and regarding timeliness. And I'm just curious to know, timeliness to assessments. You mentioned that while we had the original Department of Justice settlement agreement that recognized a standardized assessments to time to assessment, I'm curious to know, are we narrowing that? Do we have any time frame as to how close are we to fixing the assessment piece?
Madam Chair, committee members, Ann Jensen for the record, it's a good question. What you'll see in the data as we share that initial trend, we just started tracking this in the past 6 months. So I'll admit it's a pretty limited view, and it's very specific to kids that are in our focus population. So I'm excited to work with Allie and our Office of Analytics team to expand on that, to see if we can show some broader trends across our state for kids on the Medicaid program that are accessing assessment. So I can't speak to trends across the board, but I'll say for our focus population, we are seeing some decrease over time over these past 6 months. I'd hate to take that to the bank before we really have a broader sense of what the data looks like, though. So I'll be the first to admit we have a lot of work ahead of us on the assessment front, and we're doing that really methodically and with a lot of input from partners nationally. So at the University of Connecticut Innovations Institute, we were receiving technical assistance. I work very closely with my counterparts in other states that have implemented these types of programs. There's a lot of different ways to do it, and I think what's really crucial is that we're both collecting information in a really sensitive manner to these kids and families and not asking them to retell their stories over and over, but we're also decreasing the administrative burden for providers so we can share that information as seamlessly as possible. So I'm really excited for the specialty plan to be part of those conversations starting this spring and summer as well, because they'll have a really key role to play. But I will say our initial data view is limited. It's initially heading in the right direction, but I'd hate to really say that we're too far into it because there's a lot of work ahead of us, and happy to share what that work plan and timeline looks like if you're interested.
Thank you. Yes, I would appreciate that additional information, and please do share that. Thank you so much. Okay, I think we are good and ready to move on to the next subject.
All right. Stacy Weeks for the record, and we'll dive into justice-involved population and care. This came from a bill from Speaker Yeager, to seek a reentry, what we call the reentry justice involved population waiver. So before these waivers were approved at the federal level for decades, Medicaid has really never covered anyone who is considered incarcerated. And that can be in the jail, that can be someone in juvenile justice. And so even though we cover this population immediately, right when they leave, we're not really able to support sort of that transition. And I think the point of these waivers was really to allow people we know are getting ready to re-enter community, so 90 days pre-release. These waivers will allow Medicaid, once approved, to cover a variety of healthcare services that was included in that bill, including things like medication-assisted treatment, behavioral health care, case management, basic medical care. I will note, just to correct myself for a second, if there's an emergency and someone in a prison setting or who is incarcerated under the law is in an emergency and sent inpatient, we do cover that. But that is not always what they need, right? So people need care to prevent the emergency situation often. So this is really allowing us to get more upstream and to support individuals who often need to have their behavioral health provider already arranged when they leave, already know that they have their medications ready or already on the right medications. All of that work can start now 90 days earlier. Our team has been working really hard under Deputy Melinda Southard. She's been doing all the implementation of this waiver. Once it is approved, it will be under our Medicaid team as sort of like any other benefit that we cover. So Ann Jensen will be overseeing it at that point. But I would say that the challenge has been, we did submit it in 12/13 of 2024. It has been over a year. We were told lots of things happen, and CMS likes to tell us a lot of things, but of course never in writing. They told us verbally at one point that it would be approved in September of last year, and then we got word that all waivers were on pause at the federal level, and now we're looking at hopefully early this year. This is a really important effort, and I know that our prison system and correctional facilities and people that we work with and colleagues there are really anxious to get this funding. It will help offset costs to counties for a lot of these efforts that they are having to pay for themselves, including the state. So we are working with the vendor to really, the one thing I would say is the implementation is going to be a lot for these facilities. We did get some funding to help us build out the ability for our systems, prisons, jails, and our juvenile system to bill. And that's going to include needing to get electronic health records. So they're kind of like our school systems, right? It's like taking a system that has not really billed or been part of the healthcare system and helping them because they're non-traditional providers in some ways, getting them enrolled, getting them billing and all of that. So our team is working hard on that with a variety of vendors and thanks to a federal planning grant that we were awarded. I'm going to stop there for questions in case members have any.
Thank you for that presentation. It doesn't appear as though we have questions, so you may proceed.
Thank you, Madam Chair. Stacey Weeks for the record. Okay, so next we'll talk a little bit about our work at the Marketplace Health Insurance. So this is our Nevada Health Link. It is open enrollment season, still in Nevada, and this is where individuals who are not on an employer plan, right, who do not have coverage, adequate coverage, their affordable coverage under the ACA through their employer, or who are not in Medicaid, can go shopping. And a lot of these individuals are eligible for what we call advanced premium tax credits to help buy down their health insurance. There's been a lot of discussion at the federal level. I just want to clarify, advanced premium tax credits are not going away altogether. It's just that enhanced subsidy that was on top of the regular ACA tax credit is going away. So there was an additional increase during COVID, but I want to talk a little bit about what we're seeing, and then if there are questions, we can go from there. So we had our open enrollment start November 1st through December 31st for anyone who needed coverage January 1. We do have January 1, though, through the 15th for coverage that starts in February. At that point, they'd have to have a life condition change in circumstance to actually come in and change health plans and enroll in the marketplace. I can say that we've had some challenges regardless of the advanced premium tax credits, the enhanced ones expiring. On average, states are seeing really historic rate increases. I mean, we are seeing on average across our individual market about 26% higher. That is huge. And I will say we are seeing this similar in Medicaid, not up to 26%, but it's double digits. So there is something going on after COVID in acuity in the population, and just the cost of healthcare is really going up, and inflation is very high. And like I mentioned, losing those enhanced subsidies during this time is a challenge for families. But there are some opportunities that we have in our our marketplace. We did, unlike some states, we're setting up a new reinsurance program this year, as well as our Battle-Born State Plan, which is the public option. These programs together brought down the premium reduction, or they did a premium reduction in the market of about 7%. Which was really the target that we were looking for with the public option. And the average consumer premium cost was reduced with this new program of about 4.7 across all rating areas. You can see here the premium amounts without what we call without waiver, which means without the public option premium reduction target and the reinsurance program. And then there's with waiver, which means with the new public option and with the reinsurance program. And you can see there the rate difference by rating area. All carriers reduced premiums by 4.4% due to this reinsurance program, and our public options are roughly currently 8 to 9% enrollment, and they're anticipated, especially with consumers still shopping, we expect that to continue to go up. It was actually closer to 8% when we put this together, and now it's at the 9% mark, so it has gone up in the last week. Or 2 weeks. I can't remember what day it is. All right, so I'm going to go through this slide real quick, Madam Chair, and because I think it kind of is the whole picture, and then we'll open up for questions. So just on this slide here, and you can see on the box here, because I knew that when I put this on the PowerPoint, you probably wouldn't be able to see these numbers. So if you look at this box, and this is a snapshot in time where we are roughly right now in open enrollment. We're not done, as you can see. You can see that orange line. The one above that is where we were last year. So as you can see, we're not that far off, surprisingly, given all the rate increases, right? But I just want to note about 50% of the market right now is auto-enrolled into a plan, which means they haven't quite gotten their bill, right? When they first get their first premium bill this month, we are likely to see there's going to be probably some fluctuation here. Of those that actively enrolled, that means they came in, they shopped, and picked a plan instead of just automatically being re-enrolled in their product. About 20%-ish of those are in the new Battle-Born State Plans. But again, I think we're not going to have a good sense of where all this lands until we get through this month and see at the end of February where everything shakes out. We could have people drop off. We're encouraging people to shop. So if you can please encourage your constituents to not give up if they get a high bill, to go and shop. We do have affordable products. They may not offer all the same benefits, but we really want people to come in and shop and make sure before they decide that they are just going to disenroll and be uninsured. So our big campaign right now is please come shop and look to see what we have if you feel like your premium increase and your auto-enrolled is too high. So we'll have more information for the committee, hopefully at the end of February, kind of where things land. But I'm going to open it up for questions and to see where people are.
Thank you for that. We'll start with Senator Donyate.
Thank you, Madam Chair. First and foremost, I just want to say thank you, Director Weeks, and to your team on the implementation of the public option. I know that it took you many hours and years of implementation, and I think it's for me at least, it's a success when someone that was uninsured now finally has health insurance access. That to me is a big win, and so I just want to commend your team. I know it was a very arduous process to work with the federal government for its approval and seeing it implemented. I know it's going to take some time to see the benefits of it, so I just want to first and foremost say thank you. I know that we have exchanged offline in terms of demographic information, in terms of who are those who are being enrolled in terms of their economic situation, their job status, and so forth. And so I look forward to receiving those numbers, and hopefully that can be shared with other committee members as well. But I just wanted to ask a specific question regarding some of the concerns that we have seen, at least on the news, I know that there's hesitancy from some of the brokers in terms of enrolling patients into the public option. I want to reiterate that it is their responsibility and their ethical duty to do so. And so I want to make sure that that is being implemented correctly. And I know that the legislature allocated you some dollars to help with this process. So I don't know if this is an appropriate question for you to provide an update on how those dollars are being utilized. And I know that there's some cross-reference with the Division of Insurance to make sure that they're following the ethical code, but that's a separate conversation for another entity.
Thank you, Senator Donate, for the question. That is a very wonderful one. Jennifer Krupp for the record. Thank you to this body for approval of SB 4 in the 36th special session of the Nevada Legislature, which appropriated $1.25 million to the Battleborn State Plan public option program to help support carrier or broker incentives to enroll consumers into Battleborn State Plans. This was a challenge from our certified on-exchange brokers because they had several concerns about not being compensated in any way for the enrollment for consumers into the Battleborn State Plans, as well as there were concerns about their professional errors and omissions liability insurance, and because there was the appearance of there not being a business transaction, that they would not have sufficient coverage for that. So with the $1.25 million, we are issuing payments to brokers at the end of open enrollment once we have finalized numbers for any and all enrollments that occur into a Battleborn State Plan. We are issuing this at a flat fee, and we are considering these a grant fund to reimburse these brokers for any of their expenses and time that may have been incurred for signing these consumers up. To qualify for this grant, we have requested that all brokers take an additional certification on the exchange and it's about a 15-minute certification that walks through the Battleborn State Plans and does clarify some of the misconceptions that were brought to our attention here at the exchange in the lead up to open enrollment. And at this time, of the 794 certified brokers that we have about 70 brokers that are still outstanding who have not taken the training. So we do have active outreach that is occurring on an individual basis to those 70 remaining brokers, and we are very hopeful that they will get that certification completed. At the conclusion of open enrollment, and once we have finalized data, we will run an analysis with our open enrollment reporting to determine which consumers not only enrolled into a Battleborn State Plan and which consumers actually effectuated their coverage, which means they paid their monthly premium to make that coverage become effective. So we're expecting to get that finalized data in March. And at that point, we will issue payments directly to the individual certified brokers on the exchange. Jennifer Krupp for the record. I'm
Thank you.
happy to answer
Go ahead.
additional questions. Thank you.
Thank you. We were trying to determine whether or not we had additional questions, so I appreciate the follow-up. We do. Okay, next, Assemblymember Nadeem.
Thank you so much, Madam Chair. Thank you so much, Director Meek, for the explanation and for the presentation and for telling us such new information. My question is regarding the premium increase. One of my friends, she was telling me, even yesterday I had a talk with her, and she was telling me about her premium increase, which is from 1,000 she was paying for her insurance, and now it has suddenly jumped to 2,000. And she was like, she had to do some cuts, and she had to go from PPO, that is that she can see all the doctors, to HMO, that is the limited access to the physicians. So the people, and this is, I'm talking about the ordinary people. So people who cannot afford jumping from 1,000 to 2,000, but there's a gap. So is there any specific information or the insurance that they can get so to, instead of going without insurance and then have the health problems, what they can do? Is there any guidance on that, please?
Madam Chair, Stacey Weeks for the record. Yes, I would encourage them to go to Nevada Health Link's website, put in their information to see they may be eligible for advanced premium tax credits. Yes, it's still, there is still premium increases in a lot of the products, but if they can go in and shop, and there may be some hard decisions, unfortunately, that some families have to make. Like they may not get all the providers that they had today, or they may have to pay a higher out of pocket. I would encourage them to go to our navigators who offer assistance to individuals who are just trying to understand the coverage options in front of them, and that could be a helpful resource. There's also a broker if you prefer a broker, but there are a lot of resources to help families make some of those decisions about like how can they pick a cheaper product, and understanding when they're picking a cheaper product, what the pros and cons are of those products. Thank you.
Thank you so much.
Thank you. Members, any other questions?
Madam Chair.
Senator Titus.
Thank you. When does open enrollment close?
Thank you for the question. Jennifer Krupp for the record. Open enrollment officially closes on January 15th of 2026. However, any consumers who have completed an application but have not selected a plan as of midnight on January 15th will be given an additional 5 days to fully enroll into a plan. Any coverage that is selected during that time would begin on February 1st.
Thank you for that follow-up question, Madam Chair. Where is this being advertised that folks know that this public option has started, and that it's going to close on the 15th? Here's an option for you, as someone mentioned just now in Las Vegas, that their premiums jumped up $1,000. What's the public service announcements? How's this being rolled out? Because I've yet to. I'm fully engaged in this process, as you know. But I'm wondering about, literally as a citizen, constituent, consumer myself, haven't seen anything about what other than what I'm engaged in.
Madam Chair, Stacey Weeks, the record. I can let Jen speak specifically to some of the marketing. I think a big piece of what we do at the Exchange is market sort of shop, and please come and take a peek, because we do have this new option. There have been things like, I think at some of the hockey game, there was an ad. I will say that those ads are on TV, but it's not only just about the Battle-Born State Plan. That is an option just alongside other options. There is one rating area where, the second lowest cost silver, which is where you maximize your tax credits. There is one rating area where another carrier beat the Battle-Born State Plan, right, and came in even lower. So I think we are encouraging in our marketing strategy at the Exchange for people to shop. And Jen, I don't know if you want to talk a little bit about any of the outreach in the rural areas. I know there are navigator events too.
Absolutely. Thank you for the question. Jennifer Krupp for the record. The Exchange does have a very robust marketing and outreach campaign. In October alone, that's the most recent number that I have actual data for, but we attended, I want to say, over 100 outreach events through our navigator entities and organizations. We also have 11 grants directly to brokers to help promote open enrollment on the Exchange and help assist consumers with having an actual face-to-face person to sign up for coverage, because there tends to be a lot of questions. Within the Exchange's marketing campaigns, we have also talked quite a bit about the option of the Battle-Born State Plan, so that consumers are aware of these plans. However, the Exchange itself cannot promote any, one type of plan over another. So another avenue that we are working very closely with our carrier partners to market and provide some outreach for the Battle-Born State Plans is in with each of our carrier contracts. Each of the BBSP providers are required to submit to us for approval and execute on outreach and marketing plans. And so we've been working very closely with our 3 Battle-Born State Plans, and they have been working very hard to include these plan offerings with their existing marketing and outreach efforts. We also send out weekly newsletters. We have social media posts through NevadaHealthLink.com. Really, as Director Weeks had mentioned earlier, our biggest message this year is to encourage consumers to come onto the platform and shop, because in many cases, consumers are going to find lower plans or lower cost plans that do maximize their financial assistance and subsidies further than the plans that they may have been auto-enrolled into.
Thank you for that. And then just finally, at least on this subject, so the broker payment, it's going to be a flat rate once they can show So you're going to pay them after they do basic, we're paying them to do the job, which that's a whole nother comment. However, the rate that you're paying them, is that a standard rate that say in private insurance would pay them? How did you figure out a rate? There's been some concerns about what are we paying these folks to do their jobs?
Thank you for the question, Jennifer Krepp for the record. Through the funding that was awarded through SB4 from the 36th special session, the payment is substantially lower than what a carrier would normally pay a broker. I think on average carriers pay a per member per month that can total to, $200 or $300 a year, but with the one flat fee of $35, I mean, that's going to be significantly lower. Looking at our rate filings and our counterfactual rate filings from all carriers across the market, we anticipated potentially up to 30,000 consumers who might enroll in battle-born state plans. And so while allocating and leaving some money aside for any special enrollments that may happen in plan year 26 after the close of open enrollment so that there is funding reserved for those consumers, we just basically did flat math. And so 1.25 million divided by 35,000 came out to about $35 per enrollment.
Thank you for that. I like flat math, not emotional math. So thank you for that.
Myself as well.
Thank you, Madam Chair.
Thank you, Senator. Okay, seeing no other questions.
Okay.
Feel free to move on.
Thank you, Chair. All right, so now we're going to talk a little bit about our focus on some project updates where we're working on program viability. And I mentioned earlier just trying to really look at cost and what can we do to control spending and get more value out of our dollar. The first one here was passed last session. It was a single PBM, prescription benefits manager. We are working hard to get that up and going. We also have a single prescription drug list that went live January 1 as well, which also we anticipate will bring in additional rebate revenue that is helpful to the state. Proud to say that went up and live and is going well. So far, fingers crossed. If you have questions from anyone about their prescriptions or anything that happens and you have constituent requests, please send them over to us. We are happy to help if there's any confusion. I'm going to talk a little bit about our purchasing strategy and then our efforts around some of the federal funding maximization that we're looking at right now. We're going to do more of that over the years as well. All right, so Dr. Duncan is leading our single PBM, and she also led our single PDL implementation. Again, this comes from Senate Bill 389, and we are setting this up, and the goal was to really control the costs for for Medicaid around prescription drugs. And we're not the only state that's really looking and will be doing this. We know Ohio, Louisiana, and a couple other states. I think even Minnesota is standing up something. All states are grappling with the growing, really high cost of prescription drugs. Right now, we're working through all the different authorities that we may need with the federal government and different models to ensure that we are maximizing our premium tax still. We do not want to impact our premium tax revenues that we get to tax these the revenue or the expenditures from prescription drugs today through the managed care plans. So we probably will be getting a waiver to ensure that we can protect those revenues and still tax the expenditures for the state. We're going to be doing an RFP for vendors to help support the implementation, and that's anticipated next year. We have, as permitted in the legislation, instead of funding it then, because we weren't sure what we would need until we really work through the different models that we will be working with. We now have a sense of some of the the staff that we will need, and we will probably be coming back again later to IFC for additional money, but we'll be using some of our rebate money out of budget account 3245 to get the staff and the resources we need to implement this program. And I will just say this is not an easy task and will take several years, but our hope is that it will be definitely worth and valuable to the state in terms of controlling or at least maximizing rebates from prescription drugs. The next one here is our healthcare purchasing. This is really going to be working across all of our programs and where can we be smarter when we're contracting with carriers, even just some of our basic vendor services. We have multiple actuaries. Should we be streamlining those more? Should we be purchasing those and procuring those in a way where we're going out with all of them together so we get a better deal, for the state. So we're looking at even things like that. But then we're looking at broader, what can we do, for example, to really support PEB? We know that there are still some challenges, right? We know people, state employees, the premiums are expensive, and we need to ensure that we can pay our bills for that program. And those are hard conversations that need to happen. But what can we do from a purchasing strategy to help them? So we're going to be looking at that. We have new vendors that we will be going to BOE next week for, which is or I think maybe this week. I can't remember. One of these weeks is coming up to get these finally get these vendors on board. And so we can start to model a couple of ideas that we're going to ask them to put together some recommendations. And so we'll be modeling that and bringing some of those to the PEB board, hopefully some of those to this committee. And then obviously if there's legislative, and there probably will be changes needed or funding, we'll be bringing that next session. But happy to keep everyone up to date on that. Like I mentioned, it's really leveraging that footprint. Often it's Medicaid is the big one. It has the most money tied to it. But putting them all together and making sure that often it's the same carrier we're contracting with or the same vendor, that we're getting the best deal for all the programs from this same vendor. The other effort that's being led by Deputy Director Lynette Aaron. Oh, sorry, I forgot to stop. Madam Chair, I'll stop for questions.
Thanks. If you'll go ahead and do that next one, and then we'll stop for questions.
Okay. Thank you, Chair. Stacy Weeks for the record. A lot of this came from last session. Thanks to this body, you guys added additional staff and resources and vendor support for us not only to get our arms around our budget challenges, just in general in terms of staffing, but also to support ways to really maximize federal funds and ensure that the way we're spending them is appropriate. Lynette's been working already on some of these efforts, and I wish I could explain it. I don't know if she's here today. I think it's her birthday. But I know already she's been able to achieve, I think, $100 million in additional money for the state and for providers. So there's a lot of exciting things there, and happy to bring that to next session and update folks on some of our efforts. But we are in the process right now of getting our fiscal audit team hired and getting some of those other contracted Medicaid budget experts up and going. But I'm really excited because I do think there's opportunities not just within MVHA to leverage federal Medicaid dollars in support of efforts that improve outcomes for the Medicaid population, but also for public health. When you look at, for example, 988, we can definitely be helping on the administrative side because that service serves a lot of Medicaid recipients, as well as other public health activities like screenings and assessments and preventative services. So really looking at ways to maximize that. And Allison on our team, Jinko Herzik, will be working on that with the Department of Public and Behavioral Health. The other thing we've been doing, I mentioned this earlier, is looking at ways that we can do Medicaid academic partnerships, not just with to get physician and clinical support for our team, but also to partner, for example, with the University of Public Health, the one specifically right now, or the University, the School of Public Health, the one at UNR we've been talking to about a public health strategy or population health management strategy, and hoping we can leverage their expertise and some of their students and training too, to help us put together a larger population health strategy for all of our healthcare programs for the state. All right, I'm going to pause there, Madam Chair, and open up for questions.
Thank you. Members, questions? Okay, we have one, I believe. I'm curious to know if you could identify for us in a report form. Please don't talk through necessarily right this minute. How many waivers do we have, Medicaid waivers, and what's the administrative time it takes to do that? I know that it takes a significant amount of time to complete a waiver and to make the request. There are a number that are pending or have been pending, and I know you'll get into how many requests we have for the division as a body a little bit later in your presentation. But that is a question that continues to pop up. How many waivers do we have operational within the state?
Madam Chair, Madam Chair, Stacey Weeks, I know we have more than 5, probably 8 now. I have to go back and look. I will get you those numbers. You're correct. It takes a lot of time. Often we need to have one dedicated individual. It's also pulling data. We have to do quarterly reports on some of these waivers to CMS on a regular basis. CMS is always up in our business, wanting to know, and especially in 1115, wanting to know, is it budget neutral, right? And all the math and the time that goes into that for, budget neutral to them. And it's a lot of work, not only, like you said, getting them, but it's not like once you get them, it's done. They, instead of getting like a state plan amendment approved where a benefit is a solid benefit in our program, waivers are, we're going to test you and make sure this benefit meets all of our federal requirements. And every year there's an evaluation that we have to do, an evaluation plan, data analytics. There's just so much work that, it's not to say they're bad. They are a lot of work and time and a lot of staff time. So thank you for that question.
Thank you. Okay, go ahead.
All right. Thank you, Madam Chair. All right, let's talk a little bit about workforce capacity. We have a couple new opportunities, so it's exciting. So we have the Rural Health Transformation Project and grant, the SHARP grant, the State Health Care Access and Recruitment Program, GME Advisory Committee. There are a lot of changes last session I want to talk about, what we're doing there. And then just generally some of the work, I know the committee had questions about what we call our quadrennial rate review, but I wanted to talk a little bit about that program and kind of what it means and what it doesn't mean for this committee. So our new workforce grants, like I mentioned, are two. The big one is HR 1, established up to, it's about $50 billion across all states, but CMS advised states to at least apply for $200 million, so that's what we threw our dart at. Some states obviously applied for way more. We are learning that with the awards, but we applied for $200 million per year. You have to apply each year, though, for the funding. So each year we won't really know if we're going to get the full, billion at the end of the 5 years that we were aiming for, because each year it could be different. We did get the award. I was very excited. It's $180 million, so it's $20 million under what we asked for, which I think is a win. We have 4 initiatives that we recommended, and I will say that Melinda and her team worked really hard to engage stakeholders in a very short amount of time. I think we had 9 weeks, if not less. Once we finally got guidance about what this thing was going to be, we did a huge statewide survey, even with the cyber attack, and we kept trying to get that out, and it felt like the world was working against us a little there. But we did have multiple stakeholder meetings. We also had a subset of stakeholders that were close to the rural hospitals and the rural providers, the Primary Care Association, and a small advisory committee to our team in putting our application together. So I just want to say that thank you to all of those folks that participated, because we couldn't have come up with these on our own. We definitely felt like we got a lot of advice and support and tried to do our best to make this meaningful to rural Nevada. So the first initiative is our Rural Health Outcomes Accelerator. About 15% of that award of the $180 million we think will go to this program. I will say we're still trying to figure out if they reduced it down from $200 million, did CMS mean to reduce it out of one bucket? And we're still, there's some open questions there that we'll be having conversations with our CMS project officer about this grant and whether or not they wanted us to reduce a certain initiative. So right now we're hopeful that it's just percentage-wise the same, but we'll know more information in the coming weeks once we have time to digest this with CMS. We also have, and the Outcomes Accelerator is really focused in on what Dr. Oz and CMS is really asking a lot for, was that make America healthier again, and really focused in on chronic disease. So these initiatives really need to be focused in on improving health outcomes, and so we're creating an accelerator program for this percentage of the funding. The second one here is what we call our Rural Healthcare Flex Fund. We heard a lot from, even on way before this grant, we've heard a lot from our rural hospitals, critical access hospitals that often they can't afford to even buy the ambulance, or they can't afford to, the new x-ray machine or the mammogram, all the things that they need to support their community. Often that technology or those resources are just unattainable. This Flex Fund is to support those one-time infrastructure needs for rural communities. And so we put about 20% of the annual award into that bucket. There will be an RFA or RFP kind of process for all of these, and so there will be procurements in some ways or requests for awards, and so people can apply for the funding. And Melinda can speak more to some of those details if needed. And then the third one here is the Workforce Recruitment and Rural Access Program called RAP. The first one we were joking, it's a rope. The third one here is RAP. It's really supporting what we heard a lot from our rural communities is the inability to attract providers and physicians. So we wanted originally to do a loan repayment program, a very large one, and I think we heard very loud and clear from Dr. Oz and others that they were not interested in that for a variety of reasons. So we went back to the drawing board with our partners and decided to really focus in on a rural, GME kind of program, helping fund something like that or programs like that, as well as incentives for physicians or any type of provider that is needed in a community and a clinician, incentives for them to move there. For example, helping with housing, bonuses, one-time, salary or signing bonuses, those types of things. So we're hopeful that 40, but we put a lot of funding into that bucket because we know that is a huge need. The other piece here is around Rural Health Innovation Technology Grant. This is also something that CMS really wanted to see in our application. That was the feedback we were getting. We had a lot of, I will just be honest, multiple vendors wanting this money and still to this day. And that's not always bad, but I also want to be mindful that we want to make sure that this funding is sustainable for communities and actually is going to improve healthcare. So we want to be careful that it's not just a slush fund for every new idea, that these are meaningful, evidence-based solutions. But there are a lot of telehealth and AI, even AI tools for consumers and for residents in rural communities that could help improve health. And so that is what this bucket really is for. There's more information in the application, but at a high level, that's what these buckets are. The second one here is our SHARP grant from Special Session. So thank you to this body. It's one time $60 million. And it really is to support workforce capacity and sustainable results for care and giving funding to help really build out our infrastructure. This funding, just a reminder, we've already had a multiple requests. The money is not already ready. We need time, but also the money doesn't become available till next July. So I just want to kind of put that out there. Once it is available, we'll be coming to IFC this summer to get some additional staff and vendor support to actually do the RFP and the procurement process we need to do for that program. But we are working and looking at the access report that needs to be developed as part of this program. I'm going to stop here, Madam Chair, because I'm sure there are a lot of questions, and we can open it up for there.
Thank you. Members, questions?
Madam Chair.
Senator Titus.
Thank you. Again, thank you for all of that. I'm curious about the reimbursement for the providers and wanting to make sure that the term provider isn't just narrow into a physician, because you mentioned the one-time funding for things in rural Nevada, such as a mammogram, which is absolutely true. But we had a mammogram, we just didn't have somebody to run the mammogram. And that may not be what you think of as quote unquote a provider. So reimbursement for lab technicians, X-ray technicians, and these kind of the critical specialties that we need, wanting to make sure that list umbrellas all of the things to take this new infrastructure money that you're now giving these hospitals, but with nobody to run them. And it's not unlike in the education where we had laptops out there in these classrooms and they sat in boxes because there's nobody to teach the kids how to use it. The same with this. You can give us all the infrastructure we want, but if we don't have somebody to push the buttons or trained to understand that, it's not going to help us. So can you explain to me what that provider reimbursement pattern or reimbursement project looks like, and who in umbrellas, because there's a real need, even from just a phlebotomist?
Madam Chair, members of the committee, thank you for the question. Melinda Southard for the record. Yes, all of those provider types that you mentioned are included in this and more. We're looking at a wide variety of healthcare providers to, fulfill the infrastructure needs that we have in rural Nevada, and we want to ensure that they stay in rural Nevada as well. So everything related to the RAP initiative will be tied to a 5-year rural service commitment from those providers.
Thank you. Thank you, Madam Chair.
Thank you. And then just one follow-up with regard to, while we applied for the $200 million grant over that 5-year period, we have one awarded $180 million. I know that you noted that you are following up with CMS to figure out what was not funded. If you don't mind sharing that information once it becomes available to you. I'm also curious to know, was there something in our grant that they just did not want to fund, or is it an overall percentage reduction?
Madam Chair, members of the committee, Melinda Southard for the record. Thank you so much for the question. Yeah, so our application, the way that these grants are funded, it provides a funding formula. So there's 50% of the funding is baseline funding that's awarded to all approved applicants. The other 50% is workload funding. That funding is split into another 50-50. So 50% of the workload funding is based upon a state's rural facility and population score, which is provided in the application in all of our rural demographics information and things of that nature. That score is set and will not change throughout the life of the grant. So as soon as we submitted our application, CMS calculated that score and provided us the appropriate number of points based upon that score. The other 50% is based upon technical scores. The technical scores can go up or down depending on how a state performs each year of the grant. And it goes back to the different initiatives that we wrote into the grant, the state policy actions that the state committed to in our application, and all those different variables within the grant. So we have not received word from CMS on anything they did not like in our application. I do have a meeting with CMS next week to discuss how to submit our budget revision, which is due by the end of this month, and we will provide an update to this committee. Thanks.
Thank you for that. Okay, I think we're ready to move on.
Thanks, Madam Chair. All right, Stacey Weeks for the record. We'll talk a little bit about Graduate Medical Education Advisory Committee. Again, it's a Deputy Director, Melinda Southard, who is overseeing this program. On the right here, we have a new website that's up and going. I will say this one actually has a lot of information and is really, I think, useful. Hopefully you guys can check it out. This under SB 494 was transferred over to NVHA before it sat within OSIT, and under SB 262 we got a couple of things. We got additional $9 million when you added in that into the current appropriations for this committee and this program. It did go up to about, as you can see there, quite a bit of money. We did also get balance forward authority, so if we are not able to spend all the money, we do not lose it. We can move it forward, which is great, because before that was kind of a problem. Also, the focus with this funding is on infrastructure grants to help GME sites set up GME programs. And we know there have been challenges with that in the past. One of our first things that we were, really focused in on, it was really important to the governor's office and the governor, was to get this committee meeting. And so we've already had, I want to say, 2 meetings, and they've been very long. And we've elected a chair. We've already went through a scoring rubric for the proposals. We hired a vendor, Mercer, that has expertise in working on these types of initiatives nationwide, as well as leveraging Medicaid reimbursement increases to support providers to help this committee and to support us. We are moving forward very fast, actually, and I know we have another meeting coming up soon. And I think the meetings have been very productive. And our goal with this is to ensure that when we do select grant awards here soon for the summer, that it is a transparent process. And so we're really outlining that now with the committee. And our goal is to start the procurement for these grants and awards in the spring of this year. And then hopefully, if all goes well, we have, the committee scores them. They make the recommendations to myself. Hopefully everything is approvable. We'll be issuing those awards this summer. Whether or not we spend all the money in the first round is a question about the types of applications we get and whether or not we think they're actually viable. I will say there's been a lot of discussion about the overlap here with the Rural Health Transformation Grant as well as the other grant. So we've been talking through how do we ensure that this funding goes to programs that wouldn't otherwise qualify for those other funding sources, right? Because these are limited state-only dollars, and same with the SHARP grant. But we want to make sure that we are leveraging as much of that federal funding as we can to support other programs too. So that's part of the process. That will be part of the committee's review. And then I, as the director, will hopefully be able to weigh some of that in the final selection and looking at would this opportunity be better served under the Rural Health Transformation Grant, for example, so we can best ensure that we are fully maximizing our state dollars for these programs. I'll stop there to answer any questions.
Thank you. Committee, questions? I see none here in the South. Feel free to go ahead.
Thank you, Madam Chair. All right, so last but not least on this bucket is the Medicaid provider rate assessment. I think many of you probably know about this. It's been around for a while. It's under state law 422-2704. It's what we call our quadrennial rate review, our QRR. It's usually posted on our website. I think we're still in the process since the cyber attack of getting all that updated. We just finished our 2025 report. And we'll be issuing our 2026 report hopefully by the end of the year. It's in process. As you can see on the right here, there are the provider types we'll be looking at. This program or this effort really looks at assessing the reasonableness of rates as defined under the law, and it's based on cost reporting by providers. We've had some challenges with this process. While it's valuable for us to look at how are the costs being reported and whether or not our rate actually meets the cost that they're reporting, there are challenges with this. For example, we have a very low rate for providers to self-report their costs. We rarely get a good sample size, and that really, I think, affects the entire evaluation. So we do our best with what we get, but often it doesn't give us a real picture. I would also say there's also a flaw, and when we look at cost reporting, when you think of these providers, their costs, typically, especially if they're Medicaid primarily funded providers through reimbursement, their costs really reflect the money we give them. It's kind of a self-fulfilling prophecy, right? If we pay you $100, you're definitely not going to hire anyone more that doesn't cover that $100 doesn't cover, right? So their costs really reflect what we pay them. So again, it's kind of this vicious cycle. Like, is this really reasonable? So those are things we've been grappling with, and so some of our vendors we've been talking through. Are there other things? I think the nice thing that we do in this analysis currently is look at other states. And I think what we could be doing probably is are states looking at other factors beyond costs, and maybe we should be pulling some of those factors in. So those are things that we're thinking that should be improved in this process, and maybe we should be including some of those things in the report, not just the bare, here's the cost versus our rate. Now, sometimes it is very shocking. Sometimes it's very clear we haven't increased a rate, for example, in decades, and that is definitely telling when you look. But honestly, if we're not helping cover the cost and it's a provider that's primarily a Medicaid provider, and that's all, they mostly see Medicaid, those providers right now would not be open, right? So I think that's just the challenge of cost-based reporting. And that's why we want to look at, are there other things that we could be doing around rates, around quality incentives, outcomes, value-based payment design to really get at increases, or should we be looking at market as well, reasonableness compared to the commercial market or Medicare, for example? So like I mentioned, we just posted 2025. It was really primarily focused on behavioral health. I think I brought this to this committee last time during interim health with Chair Donate, so some of that is still the same, and a lot of these rates, thanks to this body, were addressed last session with the hospital provider tax, thanks to our hospital partners for allowing us to use that funding for behavioral health needs in their communities. We are still in the process of getting that approved, all of them with CMS, but I think there was some real wins from that report and ability for us to address those rates, including occupational therapy and others. I'll stop here, Madam Chair, and see if there are any questions.
Thank you. Members, questions? It's my understanding that we have listed the rates that will be reviewed over this next biennial cycle, and that each one of these rates is reviewed, although it's not mandatory that we make adjustments to the rates, even though we may have a recommendation. Is that accurate?
Madam Chair, Stacey Weeks, for the record, yes, because if I did that, I would not be able to pay for it. So anytime we increase the rates, there are times where we have a little extra funding and it's a low cost, right? So maybe it's $1 million in our budget. We have a surplus, there is some flexibility for us to make those choices to help providers. But often these types of rate increases are significant, and if it would be fiscally irresponsible, I think, of us as an agency to add all of these rate increases because we don't, it doesn't reflect the funding that we need from the legislature. So one of the reasons we wanted to bring a lot of those last session to you, so you guys could help us fund them. So hopefully this year, if there's money, we'll be looking at the results of 2026 and whether or not we can build out any of those into our proposals, or you guys can bring bills to also fund them. But thank you for that question.
Thank you for that statement. So to that point, there are a number of reports that are completed by your division or other state divisions that come to the legislative body that are mandated reports. And like I read 6 reports earlier this week, right? One of them was the Medicaid number of employers with 50 or more employees that have folks enrolled in Medicaid, right? So which is a very important report. But that's one of a dozen or so, and I'm being generous, right? Like there are more than a dozen reports that are completed. Is this a report that is completed and delivered to the legislature that we can understand as legislators when additional rate increases are required, so that as we go into budget committee meetings, those are rates that we have an opportunity to consider? Or alternatively, is that just specifically handled within the division and shared with the executive?
Yeah, Madam Chair, committee members, Ann Jensen for the record. These reports we believe are really crucial to share as broadly as possible, particularly given they reflect data that our providers have submitted to us. So every single one of these reports is public. It is posted on our website. You'll see the past, I believe it's 7 years posted there from the beginning of this process. We're happy, I believe it is also directly shared with the legislature, but we can confirm that and develop a process to do so if it's not already. But that is typically posted in the fall to winter of every year. So as we mentioned, that 2026 report is in process. The survey closed last month. We're processing that data, drafting the report, and it will be published the fall of this year.
Thank you. I appreciate the clarity around that. I would just also state, as you talk about what are you considering in a rate review, I think that is also essential, given that there are providers that have overhead costs to operate a facility and then other provider types that perhaps don't, right? That there are some provider types that the goal is to decrease the costs associated with institutional care by hypothetically providing a community-based service. And so as we're looking at those rates, I'm curious to know the background information that is being considered before we go out and do a quadrennial rate review. I realize that there's a significant amount of detail relative to that, but I'm just curious to know, is there a questionnaire of some sort that we do internally in the state that identifies what type of rate or provider are we reviewing as we look at reasonableness?
Madam Chair, committee members, Ann Jensen for the record. That's a great question. It is a complicated process, and that's feedback we've heard directly from providers that have said it's not entirely clear what types of services you're asking us to include and how to complete this report based on our specific delivery model. So we actually surveyed providers this summer to ask their feedback not on the actual cost, but on the process of submitting that cost. And we got really significant and very useful feedback that we're happy to summarize and share if you'd be interested. But a lot of it was, how do we better include information in the questionnaire that goes out to collect this data that specifies what we're looking for and how we use it? Some providers would, for example, to your point, only include staffing costs, and that's not reflective of the total cost of delivering that service. And so based on that survey feedback, we included a little bit more detail in terms of how we would expect and hope to see overhead costs reflected in that overall cost of care. We recognize for some providers, they actually utilized actuarial services or other kind of fiscal team members to make these calculations. That's not a resource available to most of our providers, however, and so we want to do our part to make this process as easy as possible. I'm happy to follow up and share with you a link to what that survey looked like this past fall, so you can see kind of how that guidance is, and as always, we welcome feedback from providers on this. Our team had one-on-one conversations as well with numerous providers as well as provider associations to better hear from them how that process is going and how we can improve it, and also give them a chance to ask questions on that before it's submitted. So, work in progress, and we continue to welcome feedback to make this as straightforward as possible, reflecting, knowing that each of these providers, it's a very different process.
Thank you for that clarity. Okay, I think that's all the questions. We can move on.
All right. Thanks, Madam Chair. Stacy Weeks for the record. All right, we're getting there, I promise. Medicaid, the last one here is innovation and value. I wanted to talk a little bit about some of the projects. These are the ones I get excited about. I think they're kind of new and give us new opportunities. I want to talk a little bit about the Medicaid Express that passed last session and what we're implementing with the exchange to really especially help our managed care members so they can shop and choose plans and get enrolled in real time. Also, all payers claims database, where that's at. That was passed several sessions ago, and we want to give an update on the status of that. Centralized credentialing that went live, and talk a little bit about that, and maybe kind of hint where we want to go with that program. And then value-based payment initiative, some of the efforts I mentioned earlier around our quality collaborative and things that we're doing to try to really get better value for the dollar that we spend on healthcare in this state. So hopefully this visual will be helpful. I wanted to give a quick overview of the Medicaid Express. So on the left here, there's a bubble of the people, right? And so just assume it doesn't matter. They don't know obviously people that come to the Nevada Health Link don't often know, are they Medicaid? Are they private market? Do they qualify for subsidies? And so the real goal here is to have that one-stop shop for individuals to come in, put their information in, and it gives them real time, tells them, oh, you're Medicaid. And if they're managed care eligible, which most of our population will be, or is at this point, they will move over to what we call the Medicaid Express. And there they can pick through the plans that they have available, compare networks, compare quality rankings, which is something CMS is requiring that we start to implement. So that will also be helpful to our members. And right now, there's just really not an avenue for that for our members. And the goal here is that it's just a real-time automated enrollment. This is going to take some time to implement, and I'll walk through that in a minute and kind of where we're at. But we anticipate right now about 90% of our enrollees really qualify for eligibility and enrollment through this portal. There are a percentage, the folks that are what we call our non-magi. It really is based on that tax return, the modified adjusted gross income. I think we've all seen that on our tax returns. That number there is really what this system focuses on. That is the same methodology that is used for people who shop on the exchange. So that was the point under the Affordable Care Act, was to apply the same methodology so individuals could go through one portal. And so if they are eligible under the Magi bucket, they will, as you can see the arrow, they would go down to the Medicaid Express, pick their managed care plan, compare providers, and be done, no cost. If they are determined premium tax credit eligible to shop for or not, but eligible to shop for a qualified health plan, which includes a battle-born state plan, they would then go to what you would see today, which is our Silver State Health Insurance Exchange, and compare products and be able to access any premium tax credits that they're eligible for. So that is really the plan shopping experience that we want to create for our members, and to make it feel more like health insurance and to remove any stigma that may be associated. One of the things we heard a lot from our rural hospital partners on our tour is that they have individuals that really feel that there's stigma around this, and it's not like health insurance. We want it to feel like health insurance. We want people to make educated decisions about the health plan they pick and to understand the benefits that they're receiving. And so that is really the goal here. So as I mentioned, the non-magi, which is the individuals that we consider our Medicaid age, blind, and disabled population, or anyone who's fee-for-service in that bucket who needs sort of a more touch, more assistance, would be recommended to our Division of Social Services and individuals there to help assist them with their application. But the goal here is to really get most of our Medicaid population in real time and allow them to shop for their products. And then I'm going to do the next slide, and then we'll open it up for questions on that. So right now, I just want to give an overview of who's leading this project. It's Sandy on our team. Once it's fully implemented, it will be overseen at the exchange with Ann Jensen as well at the Medicaid program to ensure the rules are reflecting the Medicaid rules. But this new solution, as I mentioned, was passed last session in our governor's recommendation budget bill, and right now, we are in what we call phase 1. We just went to BOE. We're implementing, like a lot of states have already implemented, which is where the exchange can determine eligibility. So we're doing that first, and then the phase 2 and 3 are where we really fully integrate the system of record and really transition all those individuals into the exchange product. One thing I want to mention here that's valuable to our members as we look ahead at work requirements is that this system will really allow us to help connect people with our employment resources at the state, help identify resources that help them find a job, educate them on that, but also help them see where they are in terms of meeting the work requirement. So our goal here is to really build this in a slick way that's less manual, less paper. And so work requirements, while they will be something some people will have to deal with, especially our adults without children, our expansion population, we're hopeful that this will be something that they can do in the privacy of their home and ensure that they're able to understand where they are in meeting those requirements and what resources are available to them and to get so they can stay enrolled or get coverage. The phases 2 and 3 are going to take more time. We're already on the way right now to do our platform RFP for our exchange for 2027, and this would just be rolling the fully integrated Medicaid component into that RFP as well. So that will be going out for an RFP in 2027 for phases 2 and 3. And with that, I'm going to open it up for questions. Thank you, Madam Chair.
Thank you. Members, questions? Okay, I don't see any. Thank you for that presentation. Feel free to move on.
All right. Thank you, Madam Chair. All right. Sorry, I called Jennifer up and then sorry, Jen. All right. Next slide will be All Payers Claims Database. This also is being led by Sandy Rubelit on our team for the implementation. And once it's fully implemented, Deputy Allison Herzik will be overseeing sort of the use of this program and setting up the advisory committee and all the functions around that. But it is live and health plans have been submitting claims, which is exciting. We are hopeful that full implementation, which means we can start to really look at the data and clean it and see if we, how we can access that data, will be available in early February, so next month. So it's really exciting. This will be a huge resource for the state because we will be able to not only understand cost and trends and state coverage programs like Medicaid and PEB, but also private market. And so we can really see, are people doing better, for example, in certain conditions that they're going to the ER, for example, or are they different across our markets? What's going on in cost? All of that, I think it's going to be very useful to us. We're really hopeful, and Allison will be leading a new population health management strategy that really looks at all of our markets and trying to control costs and making sure that we're aligning those efforts around population health. And so hopefully we'll be putting together here soon to be announced when, but a public use file as well, so the public can use some of this data in a way that really helps support research and just an understanding of Nevada's marketplace for insurance. And with that, I'll open up for questions.
Thank you for that. I don't see any questions down here.
Thanks, Madam Chair. Hopefully I've lulled everyone into a deep sleep. No, I'm kidding. All right, centralized credentialing. So I just want to give a quick update on this. It was Administrator Todd Rich. It's now Cynthia Leach, who actually originally did the full implementation of this, and she will be overseeing this going forward. It is fully implemented. It is a one-stop shop for our Medicaid providers to be credentialed, so they don't have to go to every health carrier for that process. And they can get paid. These credentialing decisions are valid once they are determined by our vendor in the committee that has been put together, which includes our health plans as well as state members. They will be valid with all managed care plans in our state that are Medicaid. One of the things that we're talking about and exploring, and possibly for next session, is the opportunity to expand this to other programs, maybe PEB and other opportunities where the credentialing here could be recognized in other markets. So providers really can get that done one-stop shop and not feel like once they do Medicaid, they have to go to PEB in the private market. Is there a way where we can really expand that to make it really, really, truly that one-stop shop for providers? I'll open up for questions.
Thank you. Assemblymember Nadeem.
Thank you, Madam Chair. So I want to clear with this one that one-stop shop credentialing. So if the provider is credentialed with Medicaid, he doesn't have to have the other insurances credentialed with the other insurances, or is it something different?
Madam Chair, Stacey Weeks for the record. It is something different. So prior to centralized credentialing in Medicaid, a provider would have to be credentialed by each of the managed care plans, right? So in the past, it would be HPN would credential a provider, Molina would credential the provider, Silver Summit. So it was just a process, and it's a lot of work for a provider, and there were all different timelines. And as much as we tried to streamline it, it still was clunky for providers. This process says, okay, we're all going to do one process that the state owns. The health plans are part of that process, but all the health plans that Medicaid uses honors that credentialing. I think what you're referring to is a goal that we have in the future, is a way, can we use this process for other markets to recognize the credentialing? There are obviously questions about which markets and how far we should go with that, and those are things we're thinking through, and obviously look for feedback on that from lawmakers and stakeholders.
Thank you so much. It is very helpful. Thank you.
Thank you. Members, any other questions? Seeing none. Go ahead.
Okay, so close. All right. Stacey Weeks for the record. Next is what I mentioned, our value-based payment. One of the big efforts, there's a lot going on in this space, but I wanted to mention I mentioned earlier already, the Hospital Quality Collaborative. Ann Jensen and her team are leading this, with also Dylan Mumlove at the Patient Protection Commission is participating. But we're going to be releasing here soon a value-based payment roadmap for our health hospitals and our managed care plans that we're working on with them. We are in the second year of our Quality Collaborative. It's really a requirement, actually, that they have to participate. Same with the MCOs. But the MCOs, it's in their contract, but the hospitals, it's in their provider tax arrangement where they get funding from our state-directed payments. They have to do a quality initiative or quality activity, and this is what we agreed to with CMS to do. We're hopeful that once we get moving on this, these are the four, you can see here there are four primary areas we're focused on, is really value-based payment design around maternal health, care transitions, primary care, and behavioral health. This could include it runs the gamut from, pay for performance. So if there's improvements, they get paid more, to we're going to take on risk. And if we save money and do better, we get to keep the money, the provider does. So there's a lot of ranges here, and we're working directly with those hospitals to figure out which one is the best one to work on, where they need to put some effort in, but it is something that they can succeed at. All of our value-based payment strategies must be in place for some of these areas by plan year 2027, specifically for maternal health and care transitions. And care transitions is really what we think of as someone coming out of the hospital setting back into their community, or how quickly are they cycling back to the ER? What are we doing to make sure it's successful? So we can really get at those high-cost services that we should be able to avoid if we do have a real workable care transition plan for individuals. And the goal here is to really test this out in the Medicaid space with our hospital partners, who also are all in the other markets, and same with our carriers, to see if there are opportunities to say, if this is working so well in Medicaid, can we do this in PEB, for example, or can we do this in our BBSP programs, our battle-born state plans, and really allow providers to even be more successful. The bigger the population, often the easier it is for them to perform well. When the sample size is bigger, the chances are greater. All right. Last but not least is our fun 2025 legislation implementation. Here's a quick overview. I think we did this last session too, or last interim for you guys, to give you a sense of what bills passed and what's impacting the agency. We have about 83 bills that passed, or at least legislative implementation streams is what we're calling them, across MVHA. These are all the projects that we're working on to implement for 2025. Surprisingly, it sometimes takes more than 2 years. So there are some even from last session, of a handful that are still trickling in. But right now, for example, the Division of Nevada Medicaid is working on 34 new bills and implementation projects, purchasing compliance 23, and then public employee benefits 12, and then consumer health services 4 bills from last session. And then just to give you a quick sense of where we are, 28 of them, I would say almost actually 30 now after looking at the deck I just saw, are complete. So that's exciting within a year. That's a huge win, I feel like. And 9 are close to being complete, as you can see. 7 are halfway. Then we still have 39 that are less than 50% complete, and then some of them are just sitting out with CMS, or some of them had a delayed effective date in state law. So we're not pushing those as hard right now because we're trying to prioritize our resources. We are seeking federal approval for 12 bills on the Medicaid side, including 11 state plan amendments and 2 Medicaid waivers. That's much lower than last year, or last time I sat here. I think it was closer to 34 state plan amendments. So thank you for that. And then the next, we have, like I mentioned, we try to do stakeholdering around what we're working on every 6 months. And right now we have another workshop coming up on January 27th where we'll be going bill by bill and giving a status update, like red, yellow, green, kind of where we're at with it, what the challenges are. And then we usually open it up for public comment on questions. And then real quick, going forward, like I mentioned, we have our 3-year strategic priorities that we've set forth, and we're working now on all the different objectives that fall under that. And we'll be meeting with our senior leadership team soon to kind of start to assign and make sure we've got project leads on all of this. But we're looking at, these are our 4 goals, right? Healthier Nevada, sustainable programs, reliable healthcare, and healthcare reimagined. As you can see under health improvement, there are a lot of areas and a lot of things that we're already doing to improve these now, but that we are looking at new opportunities. Some may require session activities, so we'll be bringing those to you next session. Program viability, as you can see, we're looking at a lot of different modeling on market reforms that we can bring to this body. Workforce capacity, we walked through a lot of those earlier, and then innovation, there's some new things there that we're looking at, especially even something I think that we don't talk enough about is health insurance literacy. What can we do to really help people understand how to use their health insurance effectively? So that's something else that the Exchange and Jennifer Krupp is going to be working on. And then the one thing we didn't talk about today is modern technology across the board. How do we make licensing, for example, the application process, all of that easier? More automated, more real time, more AI. Could we be leveraging AI in ways that we aren't yet to help relieve some of the burden on our staff? And then our network alignment is another area where I think we could really be improving access if we are incentivizing our providers to participate in all of our programs. So we're looking at opportunities there. And with that, Madam Chair, I'm going to stand for questions.
Thank you, Director Weeks and your team, for the robust presentation this morning. We appreciate you all being here. Members, questions? Yes, Senator.
Thank you, Madam Chair. I just had a quick question on the Medicaid Managed Care Plan and the Hospital Quality Collaborative. It looks like it references on the slide a strategic roadmap. Is that document complete, or is it still preliminary?
Madam Chair, Stacey Weeks for the record. It's almost complete. I'm going to let Ann answer. I think it's going to be coming to a website near you very soon. Ann, do you want to give an update?
Yeah, absolutely. So, Madam Chair and committee members, Ann Jensen for the record. As Stacey mentioned, we have our quality collaborative meetings quarterly. So our managed care organizations, as well as our hospitals, had a chance to preview and provide feedback on that, which we've incorporated into a final version. This will be published to our website within the next month. So look forward to sharing that more broadly. What you'll see is very reflective of Stacey's summary on our primary areas of focus. We will be updating it in the year ahead with a final measure set of quality measures that our managed care organizations and hospitals have worked together to select. So it will be an ongoing document, but hopefully will be helpful to really chart our work ahead.
Thank you, Madam Chair. Just for more commentary, I would appreciate once that process is complete, if you can go ahead and share it with us, and as well as any preliminary data that you're gathering. I have a strong interest, of course, in unnecessary emergency room visits and hospital readmissions, and so if there's anything that you can provide for that, I would greatly appreciate it. Thank you.
Members, any other questions? Okay, hearing none, I would like to say thank you again, Director Weeks and your entire team. Thank you all for being here and for offering such great commentary and education for all of our members today. Congratulations on the good work that you've done to date. I especially appreciate the 83 pieces of legislation that are being implemented by your collective divisions across the state. We as legislators are always working hard to be able to support our constituents and to improve supports and services across Nevada. So collaboratively, as we work together with you, I'm curious to know, do you have a particular resource that you would like legislators to utilize within your division? And now that you have a chief of staff, is there a recommended way that you would like for the legislators who are interested in working on healthcare policy to approach your division throughout the interim?
Thank you, Chair. Stacy Weeks for the record. I appreciate that question because we do get a lot of requests that come in. If you can email Allison Herzik, her email is on this last slide. I think for lawmakers, she will be your direct contact going forward. You're always welcome to email me too. I know many of you do, but I think if you want to start there, she always loops me in. But Allie can probably be more responsive at times than I can. I get a little buried now in my email, but thank you for that question.
Thank you. Thank you for being here today. We appreciate you. Okay, members, that leads us to a break point in our agenda. And so we are going to take a quick 10-minute break. Please don't disappear. 10-minute restroom break, grab a quick snack. We're going to come back and go through the second presentation in 10 minutes. And then we'll power through and get to lunch later this afternoon. With that, we will go ahead and take a quick recess. Okay, members, our 10-minute break is concluded. If you will all take your seats.
We can make it happen up here, Chair, if you want to.
That would be exceptional. Thank you,
Please,
Senator.
everybody, take your chairs.
Apparently, I'm not very loud up in the north.
Actually, the Chair, the speakers have been kind of going in and out, and it was somewhat difficult to hear some of the presenters in the south. And I don't know if you had the same issue up down there for us, but I think it's all better now. Thank you. And
Great,
everybody's
thank
quiet.
you. Thank you for that. Excellent. Okay, so with that, we are officially back to order. And we would like to welcome our next presenter. I believe it's day 2 on the job for our brand new director of the new Division of Human Services. So Director Rich, welcome to the table, and you may begin whenever you're ready.
Thank you, Madam Chair and members of the committee. You are correct. This is my, can you hear me now? Okay. This is my second day on the job, and it has been a few years since I've been in the hot seat, so please bear with me. Today we will be going over the Department of Human Resources, the Director's Office overview, a little bit. Actually, Ms. Weeks did a really good job of covering Senate Bill 494, so in the interest of time, I don't think we're going to cover that. I think we're going to skip that. We'll go over a little bit about our organization, our org chart. We'll talk about the fiscal and administrative overview of the Department of Health, the Department of Human Services, and the bill implementations out of the 83rd session and also the special session. And then we will have each of the divisions come up here, and the division administrators come up and speak to their own programs. Unfortunately, I don't have a lot to add today. In the future, I will. So I'm going to hand it off to the division administrators to talk about their own programs, Aging and Disability Services, Division of Child and Family Services, and Public and Behavioral Health, as well as the Division of Social Services. So next slide. So a little bit about the Director's Office. Our mission is, I'm just going to read it off the page here, the Nevada Department of Human Services promotes the health and well-being of its residents through the delivery or facilitation of a multitude of essential services to ensure families are strengthened, public health is protected, and individuals achieve their highest level of sufficiency. The Director's Office oversees all of the various programs. So as I said, ADSD, the Division of Social Services, DCFS, and Public Health. And as well, under the Director's Office, we also have the Grants Management Unit, Office of Minority Health and Equity. We also oversee the Fund for Resilient Nevada and the Fund for Healthy Nevada, as well as Victims of Human Trafficking, Grief Support Trust Account, and then the Upper Payment Limit Holding Account as well. So a little bit about our the Director's Office financial fiscal overview. Our Director's Office biannual budget totals, and this is just the Director's Office, not the department. Our biannual budget is about $272 million, and it's managed across 5 budget accounts. Within the Director's Office, we do have 35 positions that are approved through our FY26 budget. Let's skip the 494. Ms. Weeks did a really good job on that. I don't think we need to repeat that. She also talked about the agency reorganization. Won't go into that either, so we'll just go into the org chart. Just a little bit about DHS. We have 3 deputy directors. We have Christina, who's sitting next to me, Christina Hadwick. We also have Ashley Kopp, who is the deputy director of admin services, and then we have a vacant deputy director of programs. We also have administrators, Aging and Disability Services, Ricky Robb, who is out. She is the administrator of ADSD. Today, Jessica Adams will be speaking in her place. We also have Marla McDade Williams, who is the Administrator of Child and Family Services, Andrea Rivers, the Public and Behavioral Health Administrator, and Robert Thompson, who is, I believe, in Las Vegas today, who is the Administrator of the Division of Social Services. A little bit about DHS fiscal. DHS manages our biannual budget is about $4.6 billion in state and federal funds. We have about 6,600 positions within our department, so it is, I believe, the largest department in the state. 565 of those positions went over, out of the 7,000-ish, went over to the health authority during the transition last session. So a little bit about bills and the implementation out of the last legislative session. So DHS is in the process of implementing 97 bills that came out of the last regular session. You'll hear each, I'm not going to go into them because you're going to hear each division cover some of these in their portion of the presentation coming up. So I won't talk a lot about these, but obviously this is a big undertaking, 97 bills. It's a lot of work for our department. So we do also have, I think, an attachment that covers the status of each of these bills as well and where we're at. So on the 36th special session, we had a few bills that came out of that as well. AB4, SB3, and SB4 and on AB4, it's basically it requires the state to identify educational resources related to opioid use disorder and making available information on peer recovery support services. SB3, this bill allows the Division of Social Services to provide temporary assistance under extenuating circumstances. An example of this is covering the SNAP benefits during a government shutdown. So that won't be a problem moving forward, hopefully. And then SB4 provides DSS with necessary funds to help reduce the SNAP error rate. So that's really to ensure that that we can keep that SNAP error rate under 6% and avoid federal penalties moving forward. So with that, that's my little short portion, day 2, and it's good to be back. It's been a few years since I've been here, but I'm going to hand this off to Aging and Disability Services. Go ahead.
Good afternoon, Chair Brown-May and members of the committee. My name is Jessica Adams, and I serve as one of the deputy administrators over at Aging and Disability Services, or ADSD. I am joined in the south by Deputy Administrator Samantha Jaime and Agency Manager Cheyenne Pasquale. Administrator Ricky Robb does send her apologies for not being able to be here today. At Aging and Disability Services, our mission is to empower individuals and their support systems by providing resources for disabilities and aging. We connect Nevadans to services and improve their quality of life. We do this through a vision of Nevadans of all ages and abilities have meaningful lives led with dignity and self-determination. We do serve people of all ages with disabilities, as well as older adults and family caregivers. For the ADSD fiscal and administrative overview, our biennial budgets total about $1.2 billion. Our funding comes from a very diverse mix of sources, including state and federal funds, Medicaid insurance payments for services, Medicaid administrative claiming, county reimbursements, and we do have a telephone surcharge revenue for our communication access services program. We manage these budgets across 18 different budget accounts. We currently have 1,434 jobs in the current biennium, and our current staff vacancy rate as of the end of December was about 12%. So currently, the priorities within ADSD, and the next slide I'll get into a little bit more about some of the services that we are doing. We have ongoing growing caseloads. Our caseloads have been growing at rapid rates the last several years. And so our main priority right now is really working on all of our different services, how they're being offered, the methodologies for those, how we're paying for those services, and are there ways that maybe other states are doing something different that could work better here. I know for developmental services, we are going to be working very closely with Nevada Medicaid to see what other states might be doing as far as different sorts of waiver services. But that really is what we're focused on now, is how are we going to keep serving our growing caseloads with the amount of money that we all know Nevada has. So the other piece that we've been working on for a while, and this work keeps going, ADSD has grown quite a lot over the last, I would say, 6 to 8 years. And so we keep evaluating our internal infrastructure, including fiscal staff, oversight, making sure that we have everything that we need to make sure all of those 18 budgets are operating properly, and that we don't have any fraud, waste, or abuse going on. This slide contains all of the different programs within ADSD. I'll talk briefly about each of them. So as I said, we do serve people of all ages with disabilities, as well as older adults across every stage of life. Adult protective services. Within this program, we are committed to protecting and supporting vulnerable adults by investigating reports of abuse, neglect, self-neglect, exploitation, isolation, and abandonment. This program assists anybody who is 60 years or older, as well as any sort of vulnerable adult that's aged 18 to 59. The Autism Treatment Assistance Program, or ATAP, that assists families with children who are 20 or who are under the age of 20 who have a current diagnosis of autism to access critical services such as applied behavior analysis and speech therapy. Developmental Services, or DS, is the largest program within ADSD, comprised about 70% of the total budget. And this program empowers individuals with intellectual and developmental disabilities and their families at every stage of life through a wide range of different services and supports. This is done through 3 regional centers in the state: Sierra Regional Center serving Washoe County, Desert Regional Center serving urban Clark County, and then Rural Regional Center serving the rest of the state. Developmental Services also operates a 24-hour intermediate care facility for individuals with intellectual disabilities down in the south, and that is licensed for 43 beds. It's an institutional level of care. The Individuals with Disabilities Education Act, IDEA Part C. This provides oversight to the early intervention services across Nevada to ensure eligible children receive family-centered comprehensive services in their natural environment. This program just came over to ADSD in July after transferring from the director's office over to us. Excuse me. The Long-Term Care Ombudsman Program. This program is dedicated to ensuring residents of long-term care facilities receive the highest quality of care and support. They advocate, address complaints, and conduct investigations for people living in nursing homes and other long-term care facilities. Nevada Early Intervention Services, or NEIS, assists infants and children from birth to 3 to reach their full potential through specialized instruction, audiology, physical therapy, occupational therapy, speech therapy, and vision services. Nevada 211 is a program that allows Nevadans to learn about and access different vital resources such as food, housing, healthcare. This is done through a website and a call center. The Office for Community Living offers a variety of home and community-based services and programs for older adults, people with physical disabilities, and family caregivers to ensure Nevadans can maintain their independence in the home and the community. Office for Consumer Health Assistance, or OCHA. This program empowers Nevadans to navigate their healthcare rights and responsibilities with confidence. OCHA helps people understand their health insurance plans and also navigate workers' compensation issues. And then finally, we have the Office of the Attorney for the Rights of Older Persons and Persons with Physical Disability, an Intellectual Disability, or a Developmental Disability. We call this the Office of the Rights Attorney, and they provide technical assistance, education, and training to the division and others, as well as directing legislative and regulatory policy advocacy for individual rights. ADSD was asked if we had any suggested reforms to various reports that we do, and I'm going to send this one down to Cheyenne Pasquale to talk about.
Thank you. Cheyenne Pasquale for the record. The hearing aid report, which is required under 427A 610, is one that we're looking at recommending reform to. Any individual who qualifies for a hearing aid under this program as written in statute today has hearing aid coverage through other health insurance. So the CHIP program, Medicaid, or even our exchanges. We have not distributed any hearing aids since legislation was enacted. So it's good that there has been reforms to health insurance coverage. And so this really leads to an evaluation of the original intent of SB 203 and any necessary amendments. And moving on to slide 17, I'm going to start with AB 461, and then I will turn it over to my colleague. So with AB 461, this bill required ADSD to do an outreach program regarding long-term care planning. And there's a number of provisions under that. So what we've done since looking at implementation is evaluating existing websites and resources to determine what has been created prior to the bill passing and where we need to add to that. So this work is naturally part of our Nevada Care Connection work, our No Wrong Door efforts. And so we have identified additional resources to be added to existing sites and are working to reformat our long-term care planning portion of our Nevada Care Connection website, while also cross-referencing resources that already exist on Nevada 211. This bill also requires outreach to targeted populations, and this work is currently covered by federal funding. However, that funding is due to expire in 2027, so we're really looking at creating materials and having sustainable efforts beyond that federal funding. And with that, we'll turn it over to Sam.
Good morning. My name is Samantha Jaime, Deputy Administrator for ADSD. I'm here to talk about AB6. So AB6 established Fetal Alcohol Spectrum Disorder Treatment Assistance Program. It's a mouthful, under the Autism Treatment Assistance Program after our pilot period. So we've been working with internally with our policy unit to establish intake procedures, eligibility. We've been working with Medicaid on the home health model for fetal alcohol, as well as internally with the regional centers as we're establishing those eligibility parameters. We continue to refine education and training efforts to support successful implementation. This is internally with our developmental specialists, as well as externally with our providers that are interested in serving this community. As of January, we received a psychological development counselor that we are actively recruiting for, and we have received that list. We will start doing interviews, and that person will lead these efforts. And in conjunction with our policy unit, we are hoping to go live with a target date of March. And for AB 514, So this goes into effect July 1, and AB 514 gives long-term care the authority to go into mental health facilities to investigate and assist providers. So this is a success for the mental health population. Our long-term care leaders are actively working with HCQC. They've begun to develop regulations to be ready for March of 2026. And we'll go to public workshop as well. So in the meantime, we've been working on training our staff internally on mental health so that we'll be ready for that implementation too. And for challenges and barriers, I will give that back to Jessica Adams.
Jessica Adams for the record. So the one bill that ADSD has had a little bit of a challenge on is Assembly Bill 368. This was a bill that authorizes a patient in certain covered facilities or a resident of a living community with for persons with disabilities to request the installation and use of an electronic communication device in their living quarters or bedroom. This bill had a very short implementation timeline. It was signed by the governor on June 3rd with a going into effect on October 1st. So less than 4 months for us to try to figure out policy. The bill was split in between two laws that impacted various programs that we had in different ways. Within NRS 449, we have not only the long-term care ombudsman and APS that are going into those licensed places, so we needed to figure out what that policy was going to look like for them, but also that Desert Regional Center ICF is licensed under 449, so we had to put some real action as to what it would look like for someone to want a camera or other sort of communication device within their bedroom. Then NRS 435 was the other piece of the bill, and that was for our supported living arrangements within developmental services. Language was written a little bit differently, so I think overall we've still had some challenges trying to get this implemented. Excuse me. Our policy was late. And one of the reasons as well, we do have a draft policy out now, but all of our policies have to go through a public workshop. So that's really hard to find a policy, draft a policy, get all of the feedback, and then go to public workshop within a 4-month period. So one that we are still working on, but we have had a little bit of challenge and delay in trying to get that going. Chair, we're going to go into our wait list now. I didn't know if you wanted us to have questions before the wait list or wait until the end.
Thank you. Given that we're going to do all of ADSD, go ahead and finish the presentation relative to your division, and then we'll take questions.
Perfect. Jessica Adams again for the record. For the early intervention wait lists, we'll send that down to Samantha Jaime.
Hi, Samantha Jaime for the record. So for our early intervention wait list, this is really only indicative of the state program. We do have Part C here if there are any system questions as well. We have had provider shortages in all regions, and so we've tried to mitigate some of this with telehealth. We've been actively recruiting, but we do have families that are, I don't want to say waitlist, but more of a delay because they will get those services that are mandated. So some of them have waited for over a year for in-person, relying on telehealth as a temporary service delivery model. Some families may be waiting for more than one service, but no family is currently waiting for all services. So families are having developmental specialists, we are having some providers, and we're working on those. So this really shows initially what those assessments look like. And so those assessments determine that ongoing frequency. Doesn't necessarily mean that those are the services that they'll end up getting, but they do have those assessment periods. And so you can see lined up by provider type. We thought that would be the easiest way to show of what our provider shortages really look like. And then our ongoing services as well. And we broke it down by region, which is the Reno, rural, and our southern region. And I do want to point out, so this data was from end of November. We have since taken Nevada Early Intervention South out of rotation due to our wait times and the increased capacity in our community providers as well. Now I'll give it back to Jessica Adams for Developmental Services.
Jessica Adams for the record. Developmental Services, so what you are seeing on these wait lists, service coordination. Service coordination is performed by Regional Center Developmental Specialist staff. Their job is to coordinate all services and resources that the person may need in order to live as independently as possible. This waitlist is due to the number of staff that we have available to us. In the last budget, our caseload growth was funded based on the actual caseloads that were being served in February of 2025. And so as those number of eligible people go beyond what we were serving in February of 2025, a waitlist had to start for service coordination. The priority 1 waitlist, those are for adults who have been found eligible, but they have experienced some sort of unexpected and sudden loss that could result in immediate care and the inability to maintain their own health and safety. Priority 2 is everybody else who has been found eligible. You'll see most of the people are falling into that priority 2 wait list. They will be added into service coordination just based on the date in which they have been found eligible. Once we have people that are dropping out of services, or we have other ways in which that those regional center service coordinators have enough bandwidth to be able to serve more. The rest of the 4 services that are on here, these are all contracted services out to other contracted provider agencies. I am so sorry today. 80% of our developmental services budgets goes to those 4 services that you see there. Supported living arrangement, or SLA services, those are done by certified providers in residential settings, and they are the services that allow people to live out in the community safely, and they can be based or given on a broad spectrum based on different individual need, from a few hours a week up to 24 hours a day. Jobs and day training services are also done by certified community providers, and these are various different services that help with job skills, finding jobs, or other sorts of meaningful activities that somebody does during the day. Respite is a self-directed service, so this is services for people that are living with their families. It's $125 a month or $475 a quarter, just for families to get a break and for somebody else to provide care to their loved ones. And then the self-directed family support services. These are for families with eligible children under the age of 18 that live in the family home. It's up to $670 a month, in which they can again self-direct the specialized treatment that they want their child to get during that time. I will note that right now the regional centers, all 3 regional centers for all 4 of these contracted categories, we are offering new services now. So the wait lists are starting to come down some. For example, the reason why you see 0 for Rural Regional Center for respite and self-directed is they were just able to offer everybody that was on the wait list that service. So we are starting to offer some more services, and hopefully these wait lists will keep going down. As Director Weeks mentioned, ADSD is the operating entity for 4 different 1915C waivers with Nevada Medicaid. This is the people that are currently served on each waiver, along with the wait list. So we have the waiver for individuals with intellectual and developmental disabilities. That's through Developmental Services. The frail elderly waiver, and the waiver for persons with physical disabilities. The structured family caregiver waiver is a brand new waiver. So the reason why you're seeing 0 people on it is that we're still trying to get that launched. And the final waitlist slide that we have for you is a few additional programs that we have within ADSD. The Community Services Options Program for the elderly, and the Personal Assistant Services Program. Those are both through the Office for Community Living. Most of this waitlist is currently due to, there was some funding abnormalities in how the money came in, and so we actually have a work program going to the April IFC to be moving money from one budget to a different budget, and then we should be able to put some more people onto each of these programs. And then the Autism Treatment Assistance Program has a wait list currently of 156 people. So that is it for ADSD, and we're open for questions.
Thank you for your presentation. Members, questions?
Madam Chair.
Senator Titus.
Thank you, Madam Chair, and thank you for being at the table. Welcome, new director. Much appreciated that you're here and willing to assume this incredibly important task. Couple questions. First, the 211 system is your responsibility. Is that correct on one of, all right. My concern is that we kind of have a silo of these numbers and want to make sure that they're communicating with each other. We have 988, 211, and of course 911. And are you in the same programs where if somebody dials 911, they now refer to 988? At the same time, can 988 refer to 211? Do they communicate with each other?
So this is Cheyenne Pasquale for the record. 988 and 211 have been collaborating since the inception of 988. So they do cross referral. Yes.
And do you have yet any numbers on, and you can get those to us if you would, how many people are actually accessing that and how many are getting referred? Because one of the goals, of course, is to keep them out of the ER if possible, and just that mental health investment and making sure that who reaches out to those folks now. And it's not based on, we know the area code on your phone because that's not where they are. And so able to identify where that area code is, especially in the behavioral health world, is very helpful. And thank you. Thank you, Madam Chair.
Thank you, Senator. I do have a couple of questions. So first, I want to say thank you for your reporting. I appreciate the detail around the wait lists and some of the bill implementation pieces. There are also some bills or new pieces of legislation that were passed perhaps in the 2023 session or 2021 session. So I'm curious to know if you're able to provide a report as to implementation of some of those bills long term. And I would just point to medication administration for jobs and day training providers, right? The law was passed and I'm getting reports from provider organizations that they're still waiting for approval from the division to be able to deploy some of that stuff. So I'm just curious to know if there's still outstanding pieces of legislation that y'all are working to implement. And I don't expect an answer today, but I'm certainly would look forward to having an update in the coming weeks.
Jessica Adams, yes, we actually do have spreadsheets for all of the past sessions, so we can certainly look at those and get those to you. One of the things that I will note, because you mentioned the medication, it has taken some of the times when we have to do NAC changes, those regulations can take a very long time. The NAC for the medication for JDTs was changed right before the last session. It finally went through. It's still not codified in NAC, so I think there might be some confusion happening there. But we will certainly get you all of that for the last several sessions.
Thank you, I appreciate that. And then relative to the comments about the AB 368, Assemblymember Carter's bill regarding cameras, I believe that based on the conversations I'm having with my constituents who, as I'm sure you're aware, live in Betty's Village, many of them, in that there is a new residential opportunity for them to rent their own apartment. I'm curious to know, are we looking at individual apartments as that SLA provider setting? And is that where some of the confusion is coming from relative to the deployment of that camera bill, in that the resident is self-directing? And I'll just say again, I don't expect you to respond today because it is such a complex issue that I know that your division has been working through. But based on the conversations with my specific constituents who live in that community, they sign a lease it's their apartment, they should have the opportunity to put in a Ring doorbell if they want to without the state saying they can't. And I think that families are afraid. I'm going to rephrase that. I know families and individual residents are afraid that the state will refuse to serve them if they put in a Ring doorbell. And so I think that's definitely a confusion piece that we need to work through outside of this meeting.
Jessica Adams, thank you. I haven't heard specifically about the Ring doorbell, and that's something that we've already dealt with other memos in the past, so we can certainly look at that. But you are correct. Some of the language in which some of the definitions were within that bill, it's not incredibly clear what is considered a provider-operated residential SLA, because some people are living in their own places. They have their own leases, but they also have 24-hour services from SLAs. So it is a little bit nuanced, and that is one of the things that we're definitely trying to still work through.
Thank you, I appreciate that. And then I have one last question relative to the wait lists. You have them broken out by category: supported living arrangement, jobs and day training, respite, wait list, self-directed family supports. Are these unique individuals or families, or is there some duplication from one bucket to another?
Jessica Adams, for the record, there's definitely going to be duplication between SLA and JDT, possibly between SLA, respite, those sorts of things. There's not going to be duplication within each of those wait lists. Like, somebody could be on a wait list for, we have 5 different types of JDT services, so somebody could be asking for any of those types. So that's going to be counted as one person, but there certainly could be duplication between somebody wanting SLA and also wanting JDT.
Thank you for that. I appreciate the clarity. I'm curious to know, as we get better at data and managing data, if we could better track an individual and what level of support are they receiving, so that we'd know, are we serving everyone something, or are we just not serving people? I think that will help us as we look to the future of disability services.
Jessica Adams, yes. We actually just started a new case management system in July that we're hoping to be able to get some of that better data out of. I can tell you, though, that roughly only about a third of people that are served by developmental services, we currently have a total caseload of 8,650 people. Only about a third of them are served by either an SLA or a JDT provider. So 2/3 of the people served by developmental services really only have a service coordinator helping with them.
Thank you for that clarity. That was very important. Thank you for that. Members, any other questions? Okay, seeing none, thank you so much for your presentation. I think next we have the Division of Child and Family Services. Is that correct, Director?
Good afternoon, Madam Chair and members of the committee. For the record, Marla McDade Williams. I serve as the administrator for the Division of Child and Family Services in the Department of Human Services. I neglected to actually have all of my stuff prepared here, so here we go. So the first slide shows our mission and vision with the division. Really, recognizing that Nevada's families are our future, and children, youth, and families thrive when they live in safe, permanent settings. They experience a sense of sustainable, emotional, and physical well-being, and receive support to consistently make positive choices for family and the common good. So the next slide is our fiscal administrative overview. Our budget is about $835 million over the biennium. We have funding from a variety of sources, including state and federal allocations, county reimbursements, assessments, fees, and penalties. We have 21 budget accounts and approximately 1,136 positions that are approved in our legislatively approved budget. In terms of our priorities, it's prevention, collaboration, and provision of services. Really, as it relates to provision of services, the goal is to fill gaps in the system, such as providing services to children who are underinsured or uninsured, right? If they have Medicaid coverage, the hope is that there's an adequate network to provide those services, and then at the point that that network isn't sufficient or doesn't provide services to uninsured or underinsured, then we want to consider how we can meet that need in communities. We have three primary policy areas that are managed at the division. The first is juvenile justice. We have three correctional facilities, if you will, for juveniles. We have one in Elko, one in Caliente, and then one in Summit View. And Summit View houses the more higher level offenders. Nevada Youth Training Center in Elko has 54 beds. Caliente has 64 beds, and then Summit View has 48 beds. We also manage child welfare, which is foster care and adoption, as well as child protective services. For child protective services and foster care and adoption, DCFS manages the 15 rural counties. Clark and Washoe manage child welfare within their respective counties. And then under children's mental health, we have inpatient as well as outpatient services. And again, our goal is to fill gaps in the community. Desert Willow Treatment Center, which is at one point licensed as an acute facility as well as a psychiatric residential treatment facility for youth, has 47 beds in 4 units right now, providing treatment and psychiatric care to the highest needs youth in those respective settings. We are also doing a renovation project, and when that renovation is done, we'll have an additional 10 beds that we will be able to provide in the community. I do want to say, and I'll talk about this a little bit later, but we have basically closed our acute unit because of a legislative measure that was passed that required us to do juvenile restoration services. And so with the closure of that acute unit, we are contracting with private hospitals. We pay for that acute stay for those who are uninsured or underinsured or unable to get that care. And then, that's a system that we have in place right now. We also have Psychiatric Residential Treatment Facility North, which we call PRTF North, up in Reno. And it, again, also is 24-hour residential care. This is a staff-secured facility. So unlike Desert Willow is a locked facility. PRTF North is a staff-secured facility, as is NYTC and Caliente are juvenile facilities. Summit View is the only locked facility that we have for juveniles. And then we have the Mobile Crisis Response Team, which provides mobile crisis response for assessment, intervention, and support only in Las Vegas at this time. And that right now runs from 8 a.m. to 11 p.m. 7 days a week. Additional children's mental health, we have Wraparound in Nevada, which serves youth 3 to 18 with serious emotional disturbances and complex behavioral health needs. We have early childhood mental health services and children's clinical services that provide community-based outpatient, individual, and family-oriented mental health services up to 18 years of age. We have day treatment. We have early childhood day treatment for ages 3 to 6 and latency age day treatment for ages 7 to 11, and that is only in Southern Nevada. We also have an in-home clinical services team, which is a relatively small unit for us that kind of worked off of mobile crisis response, and this serves youth birth to 18 and their families, and it delivers individualized intensive clinical interventions in the home and community environment. We have the Child Care Consultation Program, serving children birth to 6 in early care and education settings, providing consultation, technical assistance, and training. And again, would just note that we have a statutory responsibility for child welfare and juvenile justice services. We do not have a statutory responsibility to provide any children's mental health services. We have authorization to provide children's mental health services, and that's how we manage. The one area, again, in being asked to look at the reports that we were asked to do and whether or not there should be some reform, the one that came to mind relates to relinquishment of youth under NRS 433B.3398. And primarily, looking at, again, as was noted earlier, the origin of the law, and is that really still what's in place today, and do we need to still do that same level of reporting, or should it somehow be revised to look differently based on the current landscape? In terms of legislative measures that were enacted. I think we're pretty proud of AB 515, which relates to adoption assistance. The legislature was generous enough last session to allow us to start making inroads into the not reserve, but into the liability that has been there for adoption assistance. It's kind of a complicated issue, but in removing the requirement that general fund dollars were not able to roll over for past certain number of fiscal years, we also were asked to do a report on how we intend to spend the rest of this liability down. And we have a deadline of February 15th to get that report done. Amber Howell, who works as a consultant for us, has been working very diligently with Clark, Washoe counties, and our rural child welfare to ensure that that report gets done, and we will be able to submit that to the legislature on time. Victims of crime compensation always has a lot of bills every legislative session, so I highlighted two here on the list, SB 62 and SB 87, that revise how the program is managed, increasing benefits or revising them to ensure that they are more accessible to victims. One that I didn't include on the list was AB 329, that now claimants now have up to 60 months from the date of a crime to make a claim, where previously it was 24 months. Senate Bill 504 relates to extended young adult support services, or what we call extended foster care for youth 18 to 21. Again, this was a very successful measure, and because we had done a lot of pre-work, we were able to implement fully basically on July 1st, and that program is moving along. For our challenges, AB 467, which is the measure that allowed for restoration to competence for juvenile offenders, we were able to stand up the program, and that's not the issue. The issue is that, to be able to take these youth, we had to close our acute unit at Desert Willow. Closing the acute unit at Desert Willow also means that we are realizing reduced Medicaid reimbursement for youth that we would have been able to bill for in our acute unit. We cannot bill, as Ms. Weeks noted earlier, right? Juveniles in the correctional system are not eligible for Medicaid, so we aren't able to bill for any of these services. It also is a challenging population for us to serve, and so we've realized significant staff challenges and workers' compensation claims, that are increasing a little because it's just a different population for us to manage. And then the other measure is Senate Bill 372, which amended the law regarding what's considered abuse or neglect of a child, and provides that a person who is responsible for the safety or welfare of a child does not commit abuse or neglect of a child solely because the person seeks to have the child admitted into a public or private mental health facility or hospital if the behavioral health needs of the child pose a risk to the safety and welfare of the family. I mean, that's the key provision of it. And what it's done is cause confusion with Child Protective Services, wondering at what point do you intervene with families which we face, I want to say, unfortunately, it feels like every day, a youth who has completed their program in a residential treatment facility is released to go home, and their parents won't accept them back. And we're faced with how we deal with those situations, and so we're working through it. We've gotten guidance from our Attorney General, but we still need to continue to work with the county jurisdictions, as well as potentially the courts, to ensure that we're all on the same page on implementing that particular measure. And that concludes my presentation. I'm happy to answer any questions.
Thank you for your presentation. We'll start with Senator Donyate.
Thank you. I had a question on specifically, thank you, Chair. I had a question specifically on SB 372. It was my understanding when we passed that bill that it was specifically in the instance of, I have to be careful because I know we curated the legislative record specifically while we were in session, but my understanding was it's only the transmission of what we wrote into state law was only in the instance if you are referring your child to a facility. It wasn't on the acceptance of them on the completion of a program. So I guess I'm just trying to understand where the problems are occurring, because from my understanding, the reason why the law was implemented was in the only instance of I am trying to help my child receive access to care, they are refusing to do so. Me looking after my child should not count as a form of abuse if it's in the best interest of protecting that child's needs. So I guess I'm just trying to understand how you're coming to that conclusion when we try to clear that up in the process of passing that bill.
For the record, Marla McDade-Williams, Senator, I can't speak for how others have come to their interpretation. I know how we, want to treat the measure, which is not filing neglect charges solely because someone wants to commit their child. But you do have to remember that for anyone to receive, particularly Medicaid reimbursement, they have to meet a certain level of care to be cared for in a facility. I can't just decide today my daughter is a problem and I'm going to commit her to a psychiatric residential treatment facility. She has to be diagnosed as needing that level of care. So you're correct. Nobody would right now we don't see those types of cases. What we see is the back end of them on release. We don't see them at prior. The issue being at prior would be, do they have an appropriate level of care that would qualify for them to be there?
Thank you. So in essence, I'm just trying to understand the complexity of interpretation for this. What would, as you're in the process of implementing the bill, is it something that you can, is there a clarification or definition or circumstances that you guys are seeking to implement through Nevada Administrative Code, or are you going to ask us, as we're working through this process during the interim, to submit a legislative change for further clarification? I guess I'm trying to understand, to what extent can this be solved through NIC, or are you mentioning that the hurdles that we're having are becoming difficult to implementation where we have to revise the bill?
For the record, Marla McDade-Williams, honestly, right, we were responding to the request from this committee to provide, talk about some of the measures that have been more difficult for us to implement. I think we are really early on in this process right now of really just highlighting that it's an issue, and then we will continue to work with stakeholders to figure out if we need to come back with additional legislative changes, or if we can just, within interpretation, settle on a consistent way to implement.
Thank you. I'm wondering if the director of the Nevada Health Authority could provide a little bit of clarity around additional information relative to this.
Madam Chair, Stacey Weeks for the record. Administrator Marla McDade-Williams is correct. This has become, it's kind of new. It came to our attention, I think, a couple weeks ago. Understanding typically if a family does not pick up their child, for example, out of a treatment facility, that child goes into the child welfare system. Otherwise, they're being held inappropriately in a residential treatment facility. The issue from our perspective, which we've been talking to DCFS about, and we'll soon be talking to Washoe as well as Clark County about, is the impact on our DOJ settlement agreement. This could be a huge issue for the state and could be a violation because if we are not going to find a way to support these children, we are having these facilities keep these kids too long when they are no longer appropriate for that setting. So that it's an issue we're definitely working on, and happy to work with Marla and others on language that may be needed or things that we can do at Medicaid to let counties know that if they're going to continue to bill for Medicaid dollars, they need to be providing this type of support to children to ensure the DOJ agreement is complied with.
Thank you for that clarity. Okay, so I hear that it is in 2 primary counties that we're experiencing the difficulty because the state is responsible for the rural county and child welfare services. So perhaps we could take this conversation more in detail and then offline to get to the root cause, so to find the solution. With that, Senator Titus.
Thank you, Madam Chair, and thank you for what you're doing. I'm curious about page 25 on your presentation where you talked about the facilities, children mental health services. And China Springs is in my district. It's not listed here, and I was just wondering about the relationship that the state has with China Springs. We'll probably do a deeper dive. It's been a conversation every session. But again, it's not mentioned anywhere. I just want to know what that looks like, and if you could give me a little update on that relationship.
For the record, Marla McDade Williams. So China Springs is operated by Douglas County. The state of Nevada has been asked, well, DCFS, through its budgeting process, has been asked to support China Springs financially. It's a juvenile detention facility, a county level juvenile detention facility. So, you know, we don't have an adversarial relationship with China Springs. We provide funding for them, but they really are a county facility. So other counties throughout Nevada manage their own detention facilities without state assistance. But I believe one of the reasons that China Springs receives state funding is because counties do want to send youth there, and so it's more, you know, those youth are moving out of their county. They're not Douglas County-based youth, and so that there's, I believe, some public policy decision that, you know, maybe the state has a role in funding part of those activities. But it is not a state facility. It is simply a facility that is budgeted for us to transfer funding to them.
Thank you for that. I just wanted to make sure that that is on this committee's radar. It is a conversation that we have on that facility because it is critically important to the rural areas that do not have their own facilities. Each county may have one or two children there. And I just want to make sure that there continues to be that communication, even though it is a county facility. The rural counties send their children, even though they're teenagers, they're still children there. And I want to make sure that conversation continues and the state continues to be an assistance to that. It's critical for rurals. And just thank you. I just wanted to make sure that it's still on the radar. Thank you.
Thank you, Senator Tice, for that and calling that out and getting it on the record. I have a question with regard to mobile crisis. I believe in your presentation you noted that Clark County is doing mobile crisis and that it's really limited. It's my understanding, though, that there may be some in Washoe County also. Is that correct?
Marla McDade Williams, my apologies for confusing you. DCFS manages mobile crisis response in Clark County. We previously managed mobile crisis response in Washoe County. However, Washoe County and DCFS went into discussion, and Washoe County wanted to take it over themselves, and so we transferred the funding that we had for that program to Washoe County. So Washoe County manages its own. Rural mobile crisis response is done by the Division of Public and Behavioral Health. So DCFS, we actively manage mobile crisis response only in Clark County right now.
Thank you for that clarity. And then on a different topic, as I'm sure you heard me ask earlier today with regard to timeliness of assessments, as part of the Department of Justice settlement agreement that we continue to talk about, kids come into the child welfare system and then we have a delay with regard to assessments. You're working cooperatively with Clark County and Washoe County, right? And then the division is working to provide the supports across the rural parts of our state. How are you making progress relative to the timeliness of assessments as kids enter the system?
Marla McDade Williams, for the record. Honestly, I don't think it's a conversation I've had with Clark or Washoe County about youth that they take into the child welfare system. You know, in this bifurcated system that we have, right, we all have our respective roles to ensure that we are able to meet our requirements to do them. You know, when it comes to assessments, though, for the child welfare services, I would have to see if there are delays in that process. I'm not aware of any delays in that process. What we often hear is that there are delays in, you know, extensive waiting lists, for example, for kids to be assessed for autism. And, you know, for someone to be assessed for autism, there's potentially a gap. I can tell you that we are in the process of implementing a program to kind of assist with our internal backlog of autism, because we've recognized that that's an issue, and so we authorized training for someone to do this. We bought the equipment. You know, we're getting ready to stand that up to help with the populations that come to us. But overall, as a system, again, I would have to verify whether or not that happens. There are assessments that we are required to do, for example, assessing youth to determine if they were commercially or sexually exploited. And there's an assessment tool that we use, and that tool is used, and I don't believe that there's a delay in it. So it's more likely, like, what level of assessment that someone is looking for, that there could be a delay because there are not enough providers. But there are a lot of assessments that are done. Not all of them are delayed, but I would have to assess to see which are.
Thank you for that. I look forward to following up on that as we look at the timeliness of service delivery, right? And just the identification of what supports are needed. Members, any other questions? Seeing and hearing none, thank you so much for your presentation. We appreciate you. And we will now move on to the Division of Public and Behavioral Health.
Good afternoon, Madam Chair, members of the committee. Thank you for the opportunity to present today. For the record, my name is Andrea Rivers, R-I-V-E-R-S, and I serve as the Administrator of the Division of Public and Behavioral Health within the Department of Human Services. I'd like to start today's presentation with an overview of our mission, vision, and purpose. We're very proud of our mission to protect, promote, and improve the physical and behavioral health and safety of all people in Nevada, equitably and regardless of circumstances, so they can live their safest, longest, healthiest, and happiest life. The staff in our division are very mission-driven, and I want to highlight the work they do daily to make Nevadans' lives happier, healthier, longer, and safer. Under fiscal and administrative overview, we have a very large and diverse agency, as I know a lot of you are aware, with staff and services being offered across the state. Our biennial budget exceeds $1 billion. However, that amount will decrease as federal COVID monies end this year. We have 27 budget accounts, each with unique programming efforts to serve the various needs of our residents and visitors. Many of our public and population-based programming is very reliant on federal funds, while our mental health services rely heavily on state general funds. There are almost 1,700 FTEs within our agency. That does not count our contractors and providers and people that also help supplement our services. Our DPBH priorities, we are large and diverse and offer many services to our communities that we serve. Our priorities are equally diverse. Though I cannot have time enough today to cover all of our priorities, I wanted to highlight that we are focusing on three main categories. Organizational improvements focused on making us a better agency, consistently improving our direct services, and supporting population health to reduce morbidity in Nevada. We have shared with this body in the past that we are actively seeking public health accreditation, and I'm excited to report that we are now just waiting on a date for our site visit to finish that process. Within our direct services, we want to thank the governor and the legislative body for the much needed and unprecedented investments to improve forensic mental health services in the state. This has ranged from appropriated funding for jail-based mental health services to the investment to build a state-of-the-art forensic mental health facility in southern Nevada. Additionally, Nevada is proud of the work to be done related to the crisis response system centered around the 988 system. We have highlighted two important reports in this in our presentation today that illustrate our efforts to respond to state health needs, which includes our Silver State Improvement Plan, as well as our recently finalized plan on behavioral health programs. DPBH responsibilities. It is impossible for me to cover all the amazing programs that we have in our agency within this one presentation, so we've summarized our sections of responsibilities. We have administrative services. This section is supported by a deputy administrator who oversees our fiscal services. This area supports 27 budgets, as noted previously, with federal, state funds, fees, and medical billing. Our contract unit currently supports 124 federal grants. This does not include private grants we may receive. 362 executed subawards to partners and vendors throughout the state, and 139 contracts. That does not include MOUs or work orders. Our HR and IT systems are overseen by a chief operations officer. As already mentioned, we have nearly 1,700 employees and contractors throughout the state. This includes 24-hour facilities. Our IT manages and supports 140 systems, applications, and databases across DPBH, as well as helping to support the DHS Director's Office programs and units. This is in addition to overseeing our data modernization efforts and statewide field service teams. Our Public Information Office handles requests and information from external partners, including outreach efforts. In 2025, for the programs remaining with DPBH, not including those that went over to NVHA, we addressed 84 media inquiries, 55 public record requests, and over 139 total requests for information. Last but not least, I'd like to highlight our newest program, which is the Public Health Infrastructure and Improvement area. This section is overseen by an agency manager who oversees public health accreditation and quality improvement, cultural navigation, and tribal services, workforce initiatives, and the primary care office, as well as public health investments, such as the $15 million that the governor and this body provided to support health districts and counties. We then have our community health services. This section is overseen by a deputy administrator and focuses on supporting the population-based programs for traditional public and behavioral health. These programs include overseeing direct services to targeted communities such as WIC, Women, Infants, and Children Program, and HIV services, to programs designated and designed to support systems for overall health improvement. These services are heavily funded by categorical federal grants. So much of the work is done in partnership with both federal and local organizations. Clinical services, this section is overseen by a deputy administrator as well as forensic director and clinical experts. These services include inpatient and outpatient mental health services statewide, as well as forensic mental health services. And finally, we have our prevention, planning, and response services. This section is overseen by our Nevada's medical epidemiologists. The goal of the state Office of Epidemiology is to prevent and respond to a variety of public health issues through disease surveillance, standardized data collection, meaningful interpretation of data, statewide standards, and centralized guidance in order to improve health outcomes for our communities. There are also several programs that focus on preparing and responding to public health needs and emergencies in the community. Okay, moving into suggested reporting reforms. We have a few listed here. As requested, we've reviewed and made some notes here. So starting with our Home Feeds Nevada study. The Council on Food Security, supported by the Office of Food Security within the Division of Public and Behavioral Health, has experienced a significant increase in workload following the 83rd legislative session, including the addition of a Home Feeds Nevada study. The study of a program administered by the Department of Agriculture. The study requires extensive coordination and research and has necessitated increasing the Council on Food Security meetings from quarterly to monthly. Monthly meetings have proven challenging due to quorum requirements and scheduling constraints for council members. The increased frequency has placed a substantial strain on the Office of Food Security staff, who are responsible for preparing and submitting 5 annual reports to the Legislative Council Bureau. Given the limited staffing and funding of the Office of Food Security, the additional reporting obligations have compromised some of the ability to effectively manage statutory responsibilities. Second is our Food for People, Not Landfills annual report. The Food for Landfills annual report was established as a subcommittee of the Council for Food Security, with all activities reported to and approved by the Council. As such, efforts are already documented in the Council for Food Security annual reporting. This report enhances duplicative of the efforts and reporting of the Office of Food Security by the Council of Food Security. Kidney Disease Advisory Committee Annual Report. The Kidney Disease Advisory Committee continues to meet quarterly, contingent on quorum, and remains committed to improving kidney disease outcomes in Nevada. However, the scope and volume of the committee do not warrant a standalone annual report. Members actively engage in identifying grant opportunities and supporting public health efforts, but the limited availability of funding has proven challenging. Okay. School height and weight obesity report. We would like to merge and propose formally merging these two reports that are legislatively required. We have done so over the past couple of years with great success in having a comprehensive report. This merging of the two reports that are required annually has aligned reporting timelines better, integrated data presentation, operational efficiency, and improved stakeholder communication for both pockets and areas, as well as consistency with public health best practice. The Diapering Resource Committee Annual Accounting Report. NRS 42A675 requires the division to administer the Diapering Resources account submit an annual report to the legislature describing any funds received, how funds were dispersed, the population served, and the purpose for which the funds were used during the prior fiscal year. This does require an annual reporting, but it has remained unfunded, and prior reports have consistently reflected no fiscal activity or expenditures. While reporting funding sources continues to be, while potential funding sources continue to be explored, opportunities are limited and time intensive, making meaningful progress to capture on an annual basis difficult. Any future funds would be administered under the oversight of the administrator of DPBH, ensuring fiscal accountability through existing controls. Eliminating this standalone report would allow for more effective use of staff resources without reducing fiscal oversight or accountability. We also have the Diapering Resource Committee Biannual Research Report. The Diapering Committee meets quarterly and fulfills advisory and research roles. However, biannual legislative reports does not meaningfully reflect the scope of impact of this work. We would like to propose transitioning to a 5-year reporting cycle, which would allow more meaningful progress to be demonstrated, reduce duplicative reporting, and provide more outcome-focused information to the legislature. Maternal Mortality Review Committee report is a collaborative report between the Maternal Mortality Review Committee and the Advisory Committee of the Office of Minority Health and Equity, as well as including the Chief Medical Officer. The report should detail a description of the incidences of maternal mortality and severe maternal mortality reviewed pursuant to the respective 24 months of the reporting period, provided in a manner that does not allow for the identification of any person, a summary of the disparities identified and reviewed, as well as plans for corrective action to reduce maternal mortality and severe maternal morbidity in the state. Recommendations from any legislator or other changes to policy to reduce maternal mortality and severe maternal morbidity or otherwise improve the delivery of health care in the state. It's noted that this report is necessary. However, revisions are recommended to avoid duplications with NRS 442.767 Section E, which requires the department to compile and publish on an internet website operated by the department a report that consists of data concerning maternal mortality and severe maternal morbidity. This report, it's due annually on April 1st. If the April 1st report continues to focus primarily on data, as currently reflected in the dashboard, which can be further expanded, the December report, which is due, could be shifted to emphasize to the findings and recommendations resulting from cases reviewed conducted by the Maternal Mortality Review Committee. This approach would reduce redundant data reporting and enhance the impact of the review committee's recommendations by ensuring they are clearly presented for review by leadership and the Legislative Council Bureau. Currently, the extensive data and narrative content of the December report tend to overshadow the review committee's core mission to prevent actionable items, recommendations aimed to preventing future maternal deaths. And finally, we have our early hearing detection and intervention report. While we won't request any changes or recommendations to this report, we would like to note that we will be offering a data dashboard in the next 6 months that will offer data meaningfully and sufficiently readily available, and this could be in replace of a hard copy report. Okay, moving to DPBH bill implementation. We have a lot in DPBH, and I know it was requested of another division. We'd be happy to provide this committee with a thorough documentation of where we're at with all of our bill implementations, but we did want to highlight a few successes, including AB 326, which allowed for a level 4 trauma center in the state of Nevada. Carson Valley Health in the Carson Valley, Minden, Gardnerville area is officially the first level 4 trauma center in the state of Nevada, after we built out an inspection and certification process, increasing patient access to care. In regards to legislative challenges, we have faced a few. AB 102, the Northern Nevada Public Health has formed an exploratory committee for establishing their own EMS office. Portions of this bill allowing youth EMS trainees is awaiting an FBI ruling for the legality of obtaining background checks on minors. This delay has been increased by the federal government shutdown. AB 484 full implementation has been delayed due to differences in current data collection scope and methods across licensing boards. But work is continued through the Healthcare Workforce Working Group for meaningful progress and continuation of efforts. SB 137, lack of appropriation on this bill, has limited DPBH's ability to fully implement. However, we have been innovative to identify multiple low to no cost solutions that address the heart of the bill. SB 273 implementation is stalled for this bill as we have some vacant positions. Progress was further delayed by the state cybersecurity incident. And finally, our DPBH waitlist information. Please note this is a snapshot from November 30th, 2025, and our waitlists do change considerably near daily. So for our statewide forensics waitlist, it consists of 213 individuals waiting for services, broken out by Clark County, Washoe County, and our rural counties. The forensic waitlist consists of individuals who have been found not competent to proceed to trial by a court in order to receive inpatient restoration treatment. We continue to partner with our county partners on ways to mitigate our forensic waitlists. Efforts include diversion programs, which involves consideration if an individual on the waitlist has a lower level charge and is appropriate to a lower level care matched to their mental health needs. When successful, people who are in diversion programs are taken off the wait list. We also have the January 2026 implementation of jail-based competency restoration efforts by Washoe County through the passage of AB 467 during the 25 legislative session. We expect this to have a favorable impact on the statewide wait list. At this time, we do not have a jail-based restoration program in Clark County, but are working with Clark County partners to establish a full restoration program in the jail. Okay, moving into our inpatient lists, waiting lists consist of individuals waiting for an inpatient bed within our civil hospitals. Individuals may be waiting in either a local emergency room or local jails for a bed for psychiatric inpatient stabilization services. Currently, Ross and Neal, located in Clark County, has 44 civil beds that are operational. Deanie Townsend, located in the Washoe County area, has 30 civil beds that are budgeted. Outpatient services vary and offer various voluntary services such as medication, clinic, counseling, and service coordination. I do have to tell you and apologize, Madam Chair and members of the committee, we do have error on this slide. Under the Northern Nevada Adult Mental Health Services, the waitlist type inpatient count 24 is correct for November 30th. Outpatient, reflected as 978 on your slide, is incorrect. That number should reflect 65. 978 is the number of people we serve. It is not the wait list. So my apologies that that error has been made. But please note that under Northern Nevada Adult Mental Health Services outpatient, the wait list is 65 people, not 978. So it is important to note that with outpatient, we have served 978 people as of that time. In the north, for Southern Nevada, we have served 2,700 people. That is our presentation today. We do have a number of subject matter experts to address any questions you may have, and we're happy to stand for any questions.
Thank you for your presentation. We'll start here with Senator Danyate.
Thank you, Madam Chair. I had a quick question regarding one of the bill implementations. It's my understanding that Senate Bill 312, which established the Tribal Health Authority, is under the purview of DHS, and if I recollect, part of the public health improvement dollars were to be allocated towards the Tribal Health Authority to essentially hire a executive director within the 2026 through 2027 fiscal year. And so I just want to make sure that we're on track to implementing that, hiring the person for it, now that we have the entity already established. I don't know if you can provide feedback on that.
Madam Chair, through you to Senator Donate. For the record, Andrea Rivers, thank you very much for the questioner, Senator Donate. I would be happy to provide a detailed follow-up to you regarding that, if that would be acceptable.
Thank you for that. We appreciate that. Anyone else, members, questions? Okay, seeing none. Thank you for your presentation. We appreciate you being here today.
Thank you so much. Happy New Year to you all.
Thank you, and to you. And now we will move to the Division of Social Services. Thank you for being here and for being patient today. You may begin when you're ready.
Good afternoon, Madam Chair and committee. For the record, my name is Robert Thompson. I am the administrator of the Division of Social Services. I have with me Deputy Cantrell, who is over program eligibility and service delivery. On slide 37, we start with our mission. The mission of the Division of Social Services is to engage individuals, families, and community partners to promote safety, stability, and well-being of Nevadans. Our vision is to support individuals and families throughout all stages of their life with the purpose of meeting immediate needs. We are really the safety net for Nevada, and everything we do is for the purpose of meeting Nevadans in crisis for food and medical needs. The Division of Social Services, our biennium budget is approximately $1.1 billion. However, what is not part of that budget is the food stamp benefits, SNAP benefits that we issue. We issue over $2 billion during the biennium in food stamp benefits, and the last report that I read indicated that was over 10% of all food sales in Nevada for grocery stores. So when we look at what we do, we are a customer service-based agency, and we always focus on the needs of our customers, the people coming in that need assistance. But when we have these conversations, we always have to remember that our customers are also the retailers. Our customers are also you. Our customers are our employees. And our customers are the Nevadans who aren't on assistance to make sure those tax dollars are being spent appropriately. So we always have all of those conversations with our customer service base needs. Our budgets, we have 9 budget accounts in our division, and there is a typo on this slide. We do not have 2,288 positions. We have 2,472 positions. The 2288 number is our full-time equivalents, but we also have additional intermittent positions that we use throughout the year. And our intermittent positions are also used as full-time positions. They are treated like all of our other employees. They're long-term employees. The Division of Social Services, with those staff that we have, are over 25 offices. Our SNAP benefits, food stamp benefits, is one of our largest programs. We take in approximately 30 to 40,000 applications per month for food stamp benefits. We oversee the TANF program, which is cash assistance to families that have children that meet eligibility criteria. We have our energy assistance program. We currently do Medicaid eligibility on behalf of the Health Authority. As we've heard through all the presentations, Medicaid eligibility will be transitioned away from, most of the Medicaid eligibility will be transitioned away from the Division of Social Services throughout the next biennium. We oversee child support enforcement, child care development, child care licensing, and as of the 36th special session, we now have a general assistance program. The general assistance program is a program that it's on the books if needed. It is not a program that is funded. There is not any employees assigned to that program. It is specifically a program in place should our lawmakers need to use it through our division to give out any special assistance due to extraordinary circumstances. The division's priorities at this time, our highest priority is our SNAP error rate. Changes in the SNAP regulations. Historically, all SNAP benefits have been paid for by the federal government and are currently being paid for by the federal government, that $1.1 billion a year that we issue. The changes in federal regulations now require states to pay part of that benefit should the SNAP error rate go above 6%. A 6% error rate is a very difficult benchmark to meet. The agency is slightly over 6% at this time. Our agency is one of the most accurate states in the nation, but we are slightly over 6%. During special session, we were allocated special funds to purchase technology that will assist us in that error rate. We are going through that process right now. The highest amount of errors that we have are client caused in our agency. Not necessarily fraud. Fraud is actually very low, and I would not want to imply that our clients are causing fraud. It is often mistakes, and it is often clients not reporting changes fast enough to let us update their case as required by the federal government. So there is technology that is available. We are putting the technology in place to monitor our cases differently than we have in the past so that we can act on those. SNAP timeliness is always one of our most important topics that we stay targeted on. We are required by federal law to be timely with 95% of our cases. We do not have a problem meeting that benchmark. I began working in this agency in March of 1996, and there was a time when we were not timely. We were one of the worst states in the nation to be timely. Our cases are now processed quickly. We are not a safety net if we are not meeting the people's needs quick enough, right? If we're letting the cases set and not getting the food stamps out, then we're not doing our jobs. We are now the 3rd most timely state in the nation in the food stamp program and the 1st in the Western region. So we are very proud of those benchmarks, but we've also learned through history that the older a case gets and sits and isn't processed, the higher chance of an error happening because the client's circumstances change and they don't tell us about those changes in circumstance. So the case could end up being processed in error. So being timely not only ties to those customers meeting their needs fast enough, it also ties back into that error rate. So we've got to keep our cases timely to keep that error rate down. So we're very proud of those benchmarks of being the third most timely state in the nation, but that also ties into how accurate we are, and we are being very accurate. It's just not quite accurate enough for those federal benchmarks, and we are working very hard to bring those numbers to under 6%. SNAP work requirements, also known as ABODs, able-bodied adults without dependents. We are re-implementing that due to requirements from the federal government, and we are going to see SNAP recipients who are currently eligible for SNAP may not be eligible in the future. They must be working 20 hours per week to be able to receive the SNAP benefits if aged 18 through 64, unless they have children in the home that are under a certain age, unless they are disabled, unless they meet very specific criteria. And we are going to have to put those work requirements in place. So not only will we need to engage those customers to make sure that they have the ability to meet the work requirements and continue receiving their SNAP benefits, we will have to be monitoring these regulations. And if those cases are approved incorrectly, it increases our error rate. So it all ties together into a holistic view to make sure that the cases are timely and accurate, and we're meeting the needs of Nevadans, and also giving those Nevadans a path to meet the SNAP work requirements should they choose to do so. A priority of ours is to continue working with the Nevada Health Authority to make sure the Medicaid Express transition goes through as needed by Director Weeks, as she talked about so much today, as we transition the Medicaid eligibility from the Division of Social Services over to the Health Authority. And we are seeing childcare wait lists, and that is a priority of ours to be watching those wait lists and bringing those wait lists down whenever possible. One of the issues that we are facing in the childcare arena is that during the COVID event, all childcare funding increased. The childcare funding exploded. We had a lot of money in the childcare world. Childcare funding levels reduced to the levels prior to COVID from the federal government, but with today's rates. We are paying today's salaries, today's expenses with yesterday's funding amounts. So that has created wait lists. We were asked to look at reporting requirements of the division to see if we could make any suggestions on changes. The Child Care and Development Biannual Report measures the child care state plan specific to children with a disability. This report is required by NRS 422A as of the 2019 legislative session. This information is captured in another report that could be shared upon request, and DSS is recommending that this reporting requirement be removed. The food stamp exchange program projects, this report was helpful several years ago. However, states only visit other states at the request of food and nutrition services or for special purposes. So we're not really reporting much on this report. We are recommending that this report could also be removed. Another report that we are recommending be relooked at is the Universal Energy Charge Report. It is required under NRS 702.280 on an annual basis. This report demonstrates that the Energy Assistance Program is expending the Universal Energy Charge funds as intended and provides information on program details. While similar information is reviewed at the federal level, this federal report does not provide the same level in detail. So we are providing a duplicate report per NRS, and we're suggesting that this report be removed. The division implementation of our bills, SB3 was created during the Silver State General Assistance Program. The Silver State General Assistance Program was passed during special session, and that is a success. But as I talked about, there's not anything for us to do at this time unless there is a crisis. The other three bills that we are mentioning today, they're not necessarily challenges or barriers in moving the bills forward, but we did want to highlight them for you. AB 212 renames the Virtual Early Childhood Family Engagement Pilot Program, and it extends this program by 2 years. We are not having issues moving the bill forward. There have been delays in the RFP process, so we wanted to just point that out. The challenge is not the intent of the bill. The challenge has just been the delay in the RFP process. The Assembly Bill 220 establishes a program to issue identification cards to unhoused individuals. The bill specifically indicated that we would be doing this as funding was available, and there is some challenge in identifying funding for that program. We believed during legislative session that we were going to be able to use opioid funds for that entire bill, and it has turned out after session that we are not going to be able to do it that way. So we are looking for other funding sources, including applying for grants. So while the bill does allow us, the bill specifically says as funding is available, so we're not out of compliance with the law, we are not able to move forward at this time unless we identify other funding. And then Assembly Bill 352 requires a person who wants to conduct a cottage cosmetic food operation, such as, oh, I've lost my train of thought. When they sell the food at the farmer's market, when they want to sell food at the farmer's market, they must apply for license with the Department of Agriculture. Our child support program must be able to suspend those licenses if a payer is in non-compliance with their child support program. And there's not necessarily challenges or barriers, but we are having to work with the Department of Agriculture, and the systems need to speak to each other, and there have been some delays in moving those forward. And we can now take any questions.
Members, do we have any questions? Yes, go ahead, Assembly Member.
Thank you so much, Madam Chair. Thank you so much for explaining it so well. And I'm so excited and happy to hear that we are third in this division of social services. Thank you so much for the excellent work you all are doing. So my question is that for the food program, you are receiving 30 to 40,000 applications. So how many are those are actually getting that benefits, and how we can improve that?
So the Robert Thompson, for the record, Ms. Cantrell will correct me if I speak wrong, but the approval rating in the food stamp program right now, I believe, is approximately 85%. Approximately 85% are approved. Increasing the percentage probably is not the target. People that come in and apply that are not eligible are not going to be eligible. People that are over income, we would not be able to aid them. We do provide resources and provide them with referrals to other resources such as food banks. The target that we are constantly trying to work on is reaching the eligible persons that have not applied. So we would want to increase the application count, and we have a robust outreach program that we are increasing daily. We're putting more sites in that want us to go out. So historically, anyone that wanted to apply for food stamps had to come into a brick and mortar building and submit a paper application. But now we go out into the community with our staff, and we go out to the homeless shelters. We go out to any actually community partner that'll have us, and we can set up shop maybe every day, maybe 4 hours a month, and set up a sign that will be there 4 hours a month. So the outreach program is what we use to increase those applications, and that is what we need to target to reach more people. But I don't think it's necessarily going to increase the percentage of applications that we approve. It would be more reaching the people that are eligible that have never applied.
Thank you so much for the great work. Thank you.
Thank you. Next, we have Senator Donyate.
Thank you so much, Madam Chair, and thank you so much for the presentation. I want to talk about some of the things that have happened during the interim between DSS, and hopefully you can provide me some level of understanding. Earlier last week, I had the opportunity to read the Rural Transformation Fund application that was submitted by the state. And on page 18 of that report that was prepared by the Nevada Health Authority, it mentioned that DHS was responsible for submitting a waiver through SNAP. And it mentions that it has the support of the governor that would restrict the purchasing of certain foods for eligible recipients. And so it's my understanding that such proposal hasn't had any public deliberation or legislative input, as it was not mentioned to the Interim Finance Committee. So I guess my first question is, can you provide us with an understanding of what the waiver entails, when the waiver was submitted and where it's at today, and as well as who made the decision internally to apply and submit the application?
Robert Thompson for the record. So the policy decision to move forward with that waiver actually began when I first came in as administrator. That was almost 4 years ago when the first conversation started under Director Whitley under the previous governor. So Director Whitley had come to me as the administrator and asked us to move forward with pursuing these types of waivers to restrict sugar drinks. And at that time, it was strictly sugar drinks. Through the conversations with Food Nutrition Services, we did add in energy drinks and candy. Candy that was added to that were strictly sugar candies, candy that is 100% sugar. It is not candy bars, it is not the Snicker bars, it is strictly gummies or jelly beans, those types of sugars. But I do think that it is important to talk about, while that waiver was part of the application that you're referring to, there is a second waiver that we're moving forward on too that is not part of that, because we do want to increase access to people that have food stamps to be able to buy hot food items. So it was a twofold conversation. It was restricting the sugar, which is, I believe I've answered the question that started under Richard Whitley, but we also want to provide the opportunity to allow SNAP recipients to buy hot food in the grocery stores, such as rotisserie chicken, to increase protein intake and for their convenience. And we've also seen that often those rotisserie chickens are actually cheaper than buying full chickens or the raw chickens that they have to cook. And people that are sometimes homeless, living in motel rooms, don't have access to those hot foods. So it was a twofold conversation. It was the reducing sugar intake, but also increasing the convenience and buying hot foods. But the second one wasn't part of that grant. That's why it didn't show up in that grant application. But I'm not sure I answered all of your questions. I think I missed something.
Sure. So I think, so the question, the difficulty that I'm having, right? The conversation of the waiver regarding SNAP recipients being able to receive hot foods, we've had that discussion multiple times in committee. That actually was brought up back in the 2023 legislative session. But this is, from my understanding, at least since I've served in the legislature, where I have heard that that the division or the department is going after a waiver specifically to start prohibiting the restriction of purchasing of certain foods. And so it's hard to have the balance where you're expanding access on one and now you're deterring or eliminating the ability to purchase. And so I guess the question that I have is, where is that application? Has that already been submitted? And is it still in the deliberation process? Is it still subject to public input? Where are we in terms of implementing it?
Good afternoon, Kelly Cantrell for the record, Deputy Administrator of the Division of Social Services. The waiver has not yet been submitted. We are still talking to retailers. We're still talking to folks, states who have implemented. We are trying to, the definition of what is being excluded has been refined and refined again. So we have not submitted it yet. We have been talking with multiple entities outside of our division to try and narrow this down and get this specifically as easy as possible for the retailers and as comprehensive as possible, because we've seen some pitfalls with this waiver that's been stood up, but we have not yet submitted because we are still trying to refine the definitions of everything. We're close though.
Thank you. And just as a further follow-up, I think one of the questions that's going to come up, which again, this is why public input is important. is DSS prepared to navigate the complex challenges that's going to come with such changes to SNAP purchasing? Specifically, one, are we going to be prepared with navigating the complexity of lists that we're going to have to be prepared for, and the technical point of sale transaction that we're now going to have to track, on top of the administrative complexity with now having to look at purchasing behaviors of consumers and of individuals that rely on such public assistance. And so I think such question is important to ask, because there, as you may have seen, there are plenty of public health associations that mention the complexity of making such decision making could be allocated instead. Essentially, when you stand up a restriction or a limitation on such program, that same effort could be expanded on, I don't know, figuring out how we can make sure that grocery stores are more available in the rules, or submitting waivers to ensure that people can purchase at farmers markets, farms directly, which, I mean, we've had this conversation before. The question becomes which one takes precedent. And so I want to make sure that you guys, if this is a waiver that you're going to go ahead and submit, are you even prepared with the administrative capacity and the funding to even implement such requirement? And I'll let you answer that before I make my last comment on it.
Kelly Cantrell for the record. The evaluation portion of this waiver is intense. It is a heavy lift. And we are today, at this moment, not 100% prepared to do this. We plan to ask for an implementation date of February of 2028 to allow us to get a comprehensive plan and to get the evaluation. There has to be surveys with grocery stores. We have to do one-on-one groups with customers. This is not an easy lift, but we know that it's going to take time. Yesterday, I spoke with the Associated Food Stores, who represent 40 of the independent stores in rural communities and small retailers like Mario's on the west side. And so we know that what's in front of us. We know that there are entities that can provide the help you're talking about when it comes to the list. Of food industry associations is one of those that can help build a comprehensive list based on the definitions that we put together. We do not have funding for this at this time. We are in the exploration process of it, and we are talking to everyone. We are trying to get all the information so that we can have a comprehensive plan before rolling live, hopefully in 2028. The retailers have told us they need as much time as absolutely possible to be able to meet the requirements of this. So we know we need time to do this.
Thank you. That information is helpful. I think just to round this out, if we are going to have a discussion on how we can improve access to healthier foods, right? I think that's kind of the point of why we have this committee. I think our chair mentioned that we're going to talk about public health throughout this interim, and that's certainly a discussion point that we can have. But the question is not whether we should restrict certain foods and so forth. I think the greater question that caused my level of concern and caution was the executive branch taking action, or certain agencies, without legislative input in terms of restriction public benefits. And that to me is a greater concern, because now we are starting to change consumer behavior without having the full deliberation or participation of the people, which can undermine the ability of services, which many of those in the rules will often feel the hardest. And so I would caution that you do not proceed with such proposal until the legislature has the ability to fully review it, either in the during this interim or the 2027 legislative session, just because of the magnitude. And it sounds like we're going to run into the roadblocks of administrative concerns and funding as well. And so I just would implore you that you have that discussion internally as you move forward.
Thank you. Senator Titus.
Thank you, Chair. I'll have a question for the Director Rich at the end, but right now, since we went down this rabbit hole here regarding what we can define and purchase of using SNAP benefits, my question is, we currently have items that are already restricted on what you could purchase, correct? i.e., currently, we can't purchase the hot foods. Currently, they can't use it for alcohol. Currently, no cigarettes and those kind of things. So it's not unheard of that there's already restrictions on purchasing using your SNAP benefits. Is that correct?
Kelly Cantrell, for the record, that is correct.
Right. So it's not totally unthoughtful as we look to expand towards healthier foods. And the reality, as Senator Donate mentioned, of if we really want to help somebody have food access, purchasing already prepared foods, which was one of the prior limits, taking them home so they don't have to cook them, or maybe they just have a microwave, that makes good sense. At the same time as we're going to expand one side, if we're going to do a more of a whole body look and what's really healthy and who decides what's healthy or not, looking at the term was refining, well, looking at refined sugars and perhaps what they're purchasing also on that list makes good sense regardless of whatever we settle on. And I understand, though, that the impact is going to be on the small, local, down the road stores that sell a lot of this, the convenience stores. And so recognizing the impact, I appreciate that. But at the end of the day, the overall health of our society and the overall cost to healthcare systems is all impacted by this. So listening to the small mom and pop stores that sell this food may be a good thing, but at the same time we need to encourage them to find, you can't sell cigarettes to them, you can't sell alcohol, you're selling refined sugars. Maybe we encourage them to have more power bars in their store. Maybe we have, encourage them to sell more healthy items. So it's going to be a win-win for everybody. But right now there's a lot of paranoia, I think, and oh my God, it's going to close us down. And that's not what the goal is. I don't think anybody on this committee wants to attack retailers and stores, but what we are here is we've talked about the cost to society of health care, what we spend, $13 billion on health care. And some of this is that we do have a chance to make real change, and perhaps it does require change of behavior. We encourage people with heart disease to go exercise. We encourage people with diabetes to change their behavior. So it's not unheard of that we're actually trying to get people to buy into healthy lifestyles. And so I'm excited about the conversation and encouraged, and I'm excited that what you're doing is actually looking at the program, willing to say, hey, maybe we should, in addition to restricting alcohol and tobacco, maybe we should restrict refined sugars, but at the same time offer that alternative in the stores to purchase healthy foods. And so it doesn't have to be the sky is falling narrative, I think, but the discussion has to be thorough, and implementation is going to be hard, and I think we all take ownership. So I guess, Madam Chair, that was more of a statement than a question. So thank you for going off, and then when we're done with this department, I'll have a question for the overall Director Rich.
Thank you, Senator. I appreciate your comments as well as Senator Donate's. I think it's important that as we look at considering this, we really are identifying what is healthy in our communities. And I want to make sure that we don't eliminate my Polish pierogi, right? Or my tortilla chips. Those are very important parts of my diet that have 3 ingredients or less many times. And so I think it's important that we identify what is healthy and what are we eliminating, not just refined sugars. And so to that, I'm going to say, can you tell this committee is hangry? And we have worked very long today. So I appreciate your dedication and your timeliness in being here. Thank you so much. I would invite Director Rich back to the table, as we do have a couple of closing questions for you. Thank you so much. Senator, feel free to ask your question.
Thank you. So first off, thanks everybody in all the departments for being here today. Really thorough. What you do is pretty amazing. And I think just how many departments really it is to take care of the citizens in the state. So I thank you for that. What I didn't hear, and is a passion of mine and engaged in it, is who is in charge, or who even cares about the hospice programs in this state. I didn't hear hospice mentioned under any department. Who follows that? Which department is hospice under? And
Madam Chair, Stacey Weeks for the record, Nevada Health Authority. Thanks to the wisdom of Director Whitley, it does live under me now, under ACQC, under licensing. But I will say Medicaid also plays an important role in monitoring access and fraud, waste, and abuse. So I would say 2 of those areas under the Nevada Health Authority have some impact on hospice in terms of the licensing, oversight, and then obviously Medicare at the federal level has a big interest in hospice.
Thank you for that, because there's a talk about healthcare vacuums or voids or areas where we just don't have it. In rural Nevada, just recently had a patient die, couldn't get her hospice because nobody would go out to this rural county, and it was very sad. And when somebody says, listen, I came here to take care of my mom and I'm from Virginia and I'm going to, if I could load her up, I'd take her back to Virginia because this won't happen in Virginia. It's very sad. She has subsequently passed away in the last week. But very sad that we have put ourselves in this corner. So hearing more about hospice, how we can increase access to hospice, and who really has jurisdiction to that and regulating that is just forefront of my mind.
Yeah, and Madam Chair, Stacey Weeks for the record. I apologize. I know that wasn't a question, but Senator, I want to just say, I think it depends on network adequacy. And so if this individual was enrolled in a private carrier insurer, that would actually be under Division of Insurance. And do we require hospice to be in network, for example, to be adequate? So I think some of those questions. If it was Medicaid, I think that it would be on us, and that would have been something our team would have had to help you and that patient secure. And then if it comes, so if it's in the exchange, if it's in the private market, even I think to some extent, just generally the individual market, that would be Division of Insurance. So it might be worth looking at network adequacy standards, and obviously we should be looking on the licensing side to see how much, what that process is. And sometimes there is provider abrasion, right, in the process of licensing. So I think it could be a couple pieces that might need to be looked at.
Thank you for that, and thank you, Madam Chair.
Thank you. Members, any other questions? Okay, seeing none, Director Rich, I will ask you one last question that we asked a little bit earlier today. As you know, we have a number of legislators that are very interested in the issues that you report up through you. Is there a specific person or entity that you would like us as legislators to contact with as we develop our policy priorities?
Laura Rich for the record, thank you so much for the question. Leading an agency, I think any department director appreciates that. The more that lawmakers can come to us in advance and get our feedback, the better. You are all welcome to reach out to me directly or to reach out to the administrators who oversee whatever program or that area specifically that that will be impacted. We are more than happy to meet with you and discuss any potential legislation or issues that you want to bring up. But feel free to reach out to me directly or the administrators.
Thank you for that. Again, I would like to thank each of you for being here to present to this committee today. It has been a very robust presentation. We appreciate the detailed information for each of the divisions and the issue areas, as well as the recommendations of what we can continue to work on. So we will officially close those presentations. Thank you, Director Rich, for being here, and move into the next item on our agenda, which is discussion of topics related to this interim committee to be considered at future meetings. At the beginning of the meeting, members, we talked about what the work program, the policy brief that we have, and so you saw what we worked on during the last interim and during the last session. As a matter of just getting it back on the record, our priority issues of study during this interim are maternal, fetal, and infant health, mental and behavioral health, public health, healthcare, workforce, and healthcare innovation, and child welfare. All of our meetings for this committee have been posted online, so the dates are already available. I would encourage you to mark your calendar, especially members of the public, if you're interested in these issue areas. At this time, I'd like to ask our members, are there additional or specific issues you'd like to add for consideration as we move through the interim that we have not yet added? So I'm going to open it up to you. Is there anything you want to add? Go ahead, Senator Lang.
Thank you, Madam Chair. Last session, I had a bill, Senate Bill 250, which dealt with people owning their own health records and having health records all in one place. I think that it passed out of HHS and went to finance because it initially had a fiscal note. The fiscal note was removed, but it never was able to get out of finance. I think that some of the people that had issues with that legislation are people that frankly are would be exempt from that regulation. I would like us to take a look at that. I've been meeting with a broad coalition of healthcare people that are very interested in helping make something like this move forward. And if we could discuss it in the interim, that would be great.
Thank you, Senator. So noted. Members, any other topics?
Madam Chair.
Senator Titus.
Thank you. I was waiting for Southern Nevada to come forward first, but if there's none, I have some ideas. First and foremost, Madam Chair, thank you for asking these departments to come up with their ideas on maybe burdensome regulations, reporting issues, and their own priorities. If perhaps we could have staff get us a copy of those from each department instead of looking through all these documents and pages, if we could have just a list of what the department's priorities were, and then some of the individual, all of the ones that they asked for, perhaps that we could decrease some of that burden of them reporting, et cetera. So if we could have that in like a white paper or something, that would be helpful, and that might help us guide us going forward, not just on a topic, but solutions, as we talked about early into here in this process. We get 15 bills. There was probably 30, if not more, suggestions of improvements. So it would be helpful, I think, if we had, since we're a single subject rule when we produce our BDRs, if some of these reforms and requirements we could put into, say, a single bill, so that we're not using up, because there was 30 requests here. We have 15 bills, and some of them are very specific on where they're going with that. So it would be real helpful if we could have staff, our council, look at what ones of these we could do, and as a single, perhaps BDR, to say, hey, this reporting requirements, these all follow a single topic, maybe single pages in the NRS. Maybe we could clarify that, and then actually have a presentation on those subjects, on more details on why do that height and weight requirement. Maybe we could get into one bill, or get that eliminated and merge it into another, bill or something along those lines. I think that would be very productive, because I'd like us to see even do better than we did last session, although getting 8 out of 14 is really probably the record for this committee. I'd like us to see even do better with good use. We really truly have an opportunity to change the healthcare in this state. And so some of the things that the department has already identified as really needing to happen, we really should be pursuing that. Thank you, Madam Chair.
Thank you, Senator, for that comment. I agree, which is why we asked for them to bring forward their recommendations. I think administratively there are burdens that we place that we don't recall having or requesting a report. Additionally, I would just like to note that while we're receiving the recommendations from each of the divisions that will come up before us, and encourage the public to do the same, that I've asked for staff to follow up and ask for some additional details with regard to justification for each of those recommendations. There are times, I think, that the legislature is requiring or requesting and passing a law to ask a division to do something. And so we want to make sure that we're not eliminating the progress that we're attempting to make while asking for revisions to decrease the administrative burden associated with just the law. And so I thank you for that. Know that the staff will work on that report, and then we will share it with each of the members as we progress throughout this interim. Members, are there any other recommendations that you would like to see as we progress to move forward?
Chair?
Go ahead, Assembly Member.
Thank you, Chair. I'm very much looking forward to the February meeting that addresses maternal, fetal, and infant health, and I'm also interested in sort of a focusing on health disparities and particularly in that subject area.
Noted. Thank you for that. Members, any other topics? Okay, thank you for that. We'll go ahead and add that to work session. I do want to at this time bring up that there was originally on this agenda the update with regard to HR 1 and that federal piece of legislation that is affecting so many of our state departments and divisions. As you'll note, our agenda went long today just with the 2 divisions and all of the progress that we worked on in the last legislative session and moving into this interim. As a result, we are requesting from Legislative Commission an additional meeting for this committee. We have preliminary approval, so we will look to add a 7th meeting that will specifically address the effects of HR 1 on the state. And then we will invite each of the departments that's being affected. So not typically in front of this committee would be the Department of Agriculture. However, they will have a big part of that, the Department of Corrections. And so we are interested in learning about the federal effects that are going to have potential ramifications to so many of our departments. So we will request a specific meeting. I would ask you, our current schedule, members, is about 6 weeks apart. We do have a break in between 2 of our meetings. And so I'm curious to know if you would share your availability with staff. Between the March 31 and May 12 meeting, we would look at identifying a 7th date. And so feel free to reach out to staff if you don't mind with clarity around availability. And I would ask you today, is 9 a.m. on a weekday appropriate for your schedules? Okay, I have a thumbs up in person. Okay, we have a thumbs up. Thank you for that clarity. Thank you. Okay, thank you very much for that. We will now move to the next item on our agenda, which is the second public comment period. For those of you who are here in physical locations, please move forward to the tables. Remember to clearly state and spell your name. You will have 2 minutes. And we will time each of our speakers. I would like to just remind those who may be on the telephone line, if you would like to offer public comment on the telephone, dial in. Dial 888-475-4499 and then provide the meeting ID, which is 891-2994-9350 and press the pound sign. So with that, we will go ahead and start here in Las Vegas. State and spell your name for the record. You may begin when you're ready.
Good afternoon, Chair and members of the committee. My name is Lee McAllister, McAllister. I am the Executive Director of the Nevada chapter of the American Academy of Pediatrics. I appreciate having a moment to express my sincere appreciation for Nevada Health Authority's presentation on school health today. On behalf of our 290 pediatrician members across the state, I want to say clearly we stand ready to support this school health plan. For many of our pediatricians, these are challenging times. We often find ourselves navigating a storm of barriers, families struggling to access care, the persistent noise of medical misinformation, and growing anxiety around life-saving vaccines. In this landscape, the Nevada Medicaid School Health Plan is a genuine bright light, a green spot of growth in a difficult environment. Because schools are where the vast majority of our children are every day, this plan is a vital opportunity to meet them where they are within truth, safety, and care. To ensure this light reaches its full potential, school health must be anchored in evidence-based best practices. Our school health chapter champion, Dr. J.P. Vilay, is available to ensure we are adhering to the highest American Academy of Pediatrics standards. One essential tool for this plan is Nevada PAL. This is a statewide grant-funded peer-to-peer line that connects pediatric physicians and advanced practice providers with a child psychiatrist. It bridges the gap between a student in need and the specialized care they deserve, empowering school-based staff to provide a higher level of mental health support on the spot. We are deeply grateful for the vision shown by the Health Authority today. We look forward to being a partner in turning this plan into a reality for Nevada's children. Thank you.
Thank you. Okay, seeing no one else in Las Vegas for public comment. I don't see anyone at the table. Thank you for that shift in Carson City. Let's go to the telephone lines. AVH, is there anyone on the telephone who would like to offer public comment at this time?
Thank you, Chair. If you would like to provide public comment, please press *9 now to take your place in the queue. Again, to provide public comment via the phone line, please press *9 to join the queue.
Good day, Madam Chair and members of the hardworking committee. This is Dora Martinez. Chair, I want to take the opportunity to thank you. I don't know if you remember, but I remember when you did a presentation at one of the self-advocacy conference, you said when you see something, say something, and you came to me and you said, Dora, when you hear something, advocate for it. So based on the presentation regarding work, 20 hours on work week, which is really great for people with disability who are and want and able to work, to happen. And I'm just letting you know that in the state of Nevada, we have voc rehab to help people like myself who are blind and other disability that wants to work, yet some of us have been waiting, and we really want to do and be part of society and work. So I'm hoping that we can get a partnership with you and see if the voc rehab can get on board and help people who are able to work. And thank you so much, Madam Chair. Thank you, and have a great year. See you all soon. Thank you.
Thank you, Ms. Martinez. I do remember, and I appreciate that. So absolutely, keep advocating. AVH, is there anyone else on the telephone line?
Caller with the phone number ending in 913, please press *6 to unmute yourself and begin when ready.
Good afternoon. This is Aisha Goins, AESHAGOINS with Black Joy Consulting. And I'm calling on behalf of SCIU Local 1107. And I just want to say I just appreciate the interim committee for taking the time to listen to all of the reports, and also to the chair. It is just so great to have someone that is interested in moving the conversations forward, especially as it relates to children behavioral health services. I want to thank Ms. Stacy Weeks for her report and DCSS as well. I know that we're all working to get a solution for our youth with severe emotional disturbance cycle that are cycling inappropriate placements due to inadequate licensing framework and facility capacities. I just want to remind everyone that SEIU supports the no eject, no reject policy, but we support that specifically because we just want to ensure that our children in crisis aren't turned away, and that we stand, especially I stand, to collaborate with the committee and also the departments that are available for solutions. I know that this has been a tough job and tough work, and so many things that we're learning. We're learning things in real time, but I want to just remind everyone that it's going to take a village to fix this. No one person can get it done, and no one is pointing fingers. We're all available to get the work done, and I just appreciate you and appreciate your time. Thank you.
Thank you, Ms. Goins, for being here with us all day. AVH, is there anyone else on the line?
Hello, thank you for your time today. My name is Shannon Gardner. I'm a mom of 5 kids with autism. And this year, our insurance has become so expensive and is making ABA services not attainable for our family, which is a vital lifeline for us. I can't imagine what other families are going through, but for us specifically, it's very challenging. We need attainable, affordable AV services for our family and our kids to be more independent and more capable and learn these important skills. And I thank you so much for your time.
Thank you. Before you hang up, are you able to spell your name for us? I did not hear it at the very beginning.
One moment, please, Chair. Would the last caller please press star 9 now to raise their hand and rejoin the queue if they're still on the line?
My name is Shannon Garner. It's SHANNON. My last name is Garner, GARNER.
Thank you for that. Thank you for calling back in and making sure that we have your name for the record.
If you've recently joined and would like to provide public comment, please press star 9 now to join the queue. Chair, there are no additional callers choosing to provide public comment.
Thank you, AVH. Seeing no other people here in person in Carson City or in Las Vegas wishing to offer public comment, we will close that section of our meeting. Members, thank you so much for being here for this very first meeting. Our next meeting will be held on Tuesday, February 17th at 9 a.m. And officially today's meeting is adjourned.